السلام عليكم ورحمة الله وبركاته، حياكم الله. أتمنى أن الصوت يكون واضح. My voice is clear to everyone, please.
واضح الصوت.
Mhm. طيب, excellent. Uh, I have few announcement today, and I would like to share it with you. For the some of you were asking for the program, scientific program. You can go through the scientific program over the website ICPEM. uh, uh, .co, ICPEM .co. This is the first thing. The second thing, please make sure that you will fill the evaluation form that was sent, and you will have a barcode there to answer all the question in the evaluation form. And as we mentioned, it is important for the CME, our client. Also, you have to make sure that you will attend more than 70% to be eligible to get the hours. For any question, please, regarding the conference or any suggestion, we are welcoming all your ideas and for improving the conference for the next year also. Okay. Um, Now I think the first lecture will be with Professor Marianne Gaucher-Hill. She will talk about latest pediatric advanced support guidelines and implication for care. Dr. Marianne, you can start, please.
Hi again. My name is Dr. Marianne Gaucher-Hill, and I'll be speaking to you today. Let me get in full screen. I'll be speaking to you today on the latest Pediatric Advanced Life Support Guideline and guidelines and some of the implications for care. So let's go ahead and get started. First of all, I have nothing to disclose relative to this particular lecture. So what are some of the pitfalls? I think there's several. One is in neonatal resuscitation, so treating a newborn like an infant. So we have different types of guidelines for neonates versus for children. Looking at the monitor and not the patient. Okay, we want to always see what the clinical ramifications are for any physiologic change. Latent delivering epinephrine. Epinephrine, very important, adrenaline, and really supporting perfusion for patients of all ages. Being afraid to defibrillate early, I think that's another potential pitfall. And assuming that the child cannot have underlying congenital heart disease. So we're going to talk a little bit about neonatal resuscitation because I always feel that people make it a lot more complicated than it needs to be, at least for the large majority of patients. And what happens initially, especially with the newly born, is you're trying to transition the newborn from fetal physiology to newborn physiology. And I think this is really important. And there's some things that occur at the time of delivery. Obviously, probably the biggest is that the fetus is transitioning from receiving its oxygen from its mother through the placenta to receiving oxygen through functioning lungs. And I think that is probably the biggest transition. We do see primary apnea that occurs, and drying, warming, and stimulating the infant can help relieve that primary apnea and stimulate initially gasping and then respiration by the newborn. The key thing is if it's greater than 24 hours since the child is born, then we basically treat the infant with the same pediatric advanced life support algorithms or advanced pediatric life support. Okay, so we want to keep it simple. And I mentioned this. So for the newly born, drying, warming, and stimulating is the most important thing that can be done. And so 95% of newborns can be resuscitated just through those efforts, getting a towel and drying at the level of the perineum. Delayed cord cutting is recommended. And so really this is the simplistic algorithm. Dry, warm, and stimulate. Then you may need to ventilate, evaluate the heart rate, and then resuscitate. So a child that's blue and limp and appears lifeless can be immediately resuscitated through drying and warming. And so just because a baby is born blue and lifeless does not mean that one should not initiate resuscitative efforts. So dry, warm, and stimulate. Use suction only if there's airway obstruction. The recommendation is you don't need to do routine suctioning. But I will say those with meconium, you would use your typical bulb suction and suction the mouth and the nose. And then the next step is ventilate. When would you ventilate? If the baby is gasping and not taking respirations, or the heart rate is less than 100. And so anytime the heart rate is less than 100, you would initiate, position the head, open the airway, begin bag mask ventilation. You then evaluate the heart rate. And if the heart rate is less than 60, you would initiate chest compressions. 3 compressions to 1 ventilation. And this is a time that you might consider an advanced airway and also IV, IO access, or umbilical vein catheter access, and then initiating epinephrine. So that's basically the entire algorithm. It's a little more complicated than that, but remember you're trying to transition the baby from fetal physiology to newborn physiology. So in summarizing this again, if the heart rate is greater than 100 and there's no distress or apnea, even if there's central cyanosis present, you'd only need to give supplemental oxygen. You potentially could do some continuous positive airway pressure, so basically non-invasive. If there is respiratory distress and there's central cyanosis present, the recommendation is to go ahead and start bag mask ventilation, put the patient on a cardiac monitor and pulse oximeter. If indeed the heart rate is between 60 and 100, you want to continue supporting ventilation. At this point, you might consider supraglottic airway, but I would not do that initially. I would go ahead and bag the patient and see if you can get the heart rate to go above 100. You don't need to do any advanced airway. I would definitely put them on a cardiac monitor. Anytime you initiate bag mask ventilation, they should have a cardiac monitor and pulse oximeter. And remember, you always want to use the baby's right hand for pulse oximeters readings to be most accurate. And then under 60, this is where chest compressions, because the baby's cardiac output is equal to heart rate, really important to understand that you need to support perfusion with chest compressions if the heart rate drops below 60. I mentioned vascular access, the umbilical vein. Remember, there's 2 arteries and a vein. The vein isn't as thick-walled, and it therefore can, as shown here in the left lower diagram, blue, it can be more U-shaped versus round, like the cross-cut of the arteries. And again, delayed cord clamping. You want to hold the baby at the level of the perineum, even with the cord attached, and begin the drying, warming, and stimulating. The umbilical vein catheter, you could use a 5 French feeding tube that can be inserted with the syringe on the end, aspirating as you go. Once you want to insert it until blood is aspirated, and then go a few millimeters more and go ahead and tie it. And that can be done with an umbilical tape or even a suture. Not to suture it tight, but just to secure it. So the take home here is dry, warm, and stimulate, resuscitates almost all newborns. Delayed cord clamping, I mentioned. Leave the umbilical cord. I didn't mention this, but you want to leave it about the length of your thumb in order to allow for use post-delivery for vascular access. And then the most important thing is heart rates under 100, begin bag mask ventilation, and under 60 chest compressions. So that's the entire thing for newborn or the newly born resuscitation efforts. So now let's move to cardiac arrest. As you know, in 2025, the American Heart Association released their latest guidelines. There's really not a ton changed in looking at it compared to 2020 guidelines. They have been, I think, a little more clear about some of the triggers in terms of post-resuscitation care. So we'll talk about that in a bit. So here's the top 10 takeaways from the American Heart Guidelines. High quality CPR with ventilation in children helps improve outcomes. So although the hands-only CPR is simple to use, for any healthcare provider or clinician, doing both chest compressions and ventilation is important, and especially for any asphyxial arrest, we know that early ventilation makes a huge difference. So as an example, near drowning. Early epinephrine improves outcome for non-shockable rhythms. Really important to get that epinephrine on fairly soon. The recommendation is under 5 minutes, and really it's as soon as feasible. Rapid defibrillation is an initial priority for shockable rhythms, and I think that's really an important issue. If indeed there's an art line in place, and so this is typically in your ICU settings, also some EDs, they do establish art lines. You want to aim for diastolic pressures of 25 millimeters in infants and 30 in children. And again, looking at the map, and we'll get to that in a second, or mean arterial pressure. End-tidal CO2, you want to target to, it targets to guide termination of resuscitation, is really ill-advised. We look at end-tidal CO2 to help monitor the resuscitation, to see if there's a big increase. Sometimes that indicates return of spontaneous circulation. But any one target to decide whether you terminate or not, again, is not recommended. Post-arrest care, instead of cooling everyone, it's really to prevent elevated temperature above 37.5 degrees centigrade. You want to maintain post-arrest systolic and MAP, mean arterial pressure, greater than the 10th percentile. And then finally, neuroprognostication post-cardiac arrest is very complicated, and it really requires multiple disciplines to be involved, often pediatrics and neurology. And next, cardiac arrest survivors are going to require ongoing support for cognitive, behavioral, and physical challenges. And I think basically what it means is that there should be programs in place after cardiac arrest and survival to help support the child and the child's family in the recovery phase, which is generally, or it can be prolonged. And then finally, adenosine-resistant SVT, consider use of IV sotalol. Okay, so those were the big takeaways. So what is the scope of the problem? About 20,000 infants and children will have a cardiac arrest per year in the US. On a worldwide level, I don't know what it is, but it has to be huge in terms of what the risk is. And depending on the resources within the EMS system will depend on the response and care that's given. It is important to understand that in-hospital arrest and out-of-hospital arrest are very different. In the U.S.'s survival for out-of-hospital cardiac arrest is around 10%, maybe a little higher for adolescents. And really, I think most in-hospital arrest for children, the survival is quite high because resuscitation is generally virtually immediate. So what are some of the critical issues? One is, when do you know to initiate CPR? I love the no-no-go. The no-no-go is essentially, is the patient conscious? No. Is the patient breathing normally? No. Then go begin CPR. And I think that's really important for all of us to understand, but certainly the lay public. And there's 5 major elements of high quality CPR: adequate chest compressions with full recoil, okay, allowing full chest recoil between compressions. And it's about 1/3 of the chest diameter. And then the appropriate rate, which is 120 a minute. High compression fraction and minimalizing really any interruption is important to maintain perfusion, because we know coronary perfusion, if you stop chest compressions, drops off really immediately. And that's important to help support the heart as well as the brain. And another area, we call it the H bombs, as we call it, which are essentially hyperventilation, hyperoxia, right? Hypo or hypercarbia, and hypotension. Those are the things that can be can initiate or basically prognosticate poor outcomes if those H's are not addressed with. And then in most cases, you can delay an advanced airway. So some of the keys to survival: early chest compressions, high quality CPR, as we just mentioned, some of the high quality features, and then the ability to have post-cardiac resuscitation care. And that's generally going to be tertiary care. And so understanding within systems, where are those regional systems and transport services that can transport a child to those regional systems for ongoing care. Here's the 2025 algorithm, which essentially is very similar to the 2020, and maybe some slight differences, but the bottom line is shockable is on your left, and you can see you want to shock as soon as possible, initiate chest compressions and ventilations, and then for 2 providers, it's going to be 15-2, and go ahead and initiate defibrillation once the cardiac monitor or an AED, automated external defibrillator, recognizes that a shock should occur. For asystole and PEA or non-shockable rhythms, initiating CPR, again, oxygenation, ventilation, chest compressions 15 to 2, that an epinephrine should be given as soon as possible. So it could be by IO or IV. And real important to get that on board as quickly as possible. For every minute that it is not on board, the outcome goes down. So our first case here that we'll talk about is a 3-month-old boy found unresponsive by parents. Paramedics confirmed cardiopulmonary arrest, and the monitor shows essentially asystole. So here's the management priorities for asystole. As I said, initiate early CPR, bag mask ventilation, and then early epinephrine every 3 to 5 minutes. And in terms of the number of doses of epinephrine, we know that generally after 30 minutes of resuscitation, if the patient has not had ROS, the likelihood of survival is extremely low. All right, I mentioned about ventilation, and as you can see in the video here, it's real important to see adequate chest rise, although it doesn't need to be huge. Here, I'm supporting someone who is spontaneously breathing, but excessive ventilation decreases cerebral perfusion pressure, ROSC, and ultimately survival. So too fast and hard ventilation is going to be problematic. During CPR, you want to ventilate about 6 to 10 times a minute based on the 15 to 2 compression to ventilation ratio. And if an advanced airway is in place, then you can initiate 20 to 30 per minute with ongoing chest compressions. And once ROSC happens, definitely 20 a minute. You don't want to bag too fast. And you can say squeeze just until chest rise is initiated and then begin the release phase. Some of the pediatric airway controversies have to do with what is the optimal airway management method for the care of children in the out-of-hospital setting. We do know that data both in hospital and out of hospital demonstrates that if too early of an advanced airway may create an additional hypoxic event and therefore decreases survival. So initiate good ventilations, bag mask ventilation as quickly as possible. And then after the resuscitation, the goals of initial care, either shock, defibrillation for shockable, or initiation of epi, then you could consider an advanced airway or post-ROSC. So this is data from in-hospital cardiac arrest, and what you can see of the 2,200 patients, 68% were intubated during the cardiac arrest. And when you look overall and in terms of a propensity match cohort of patients, survival was lower in those intubated compared with those who are not intubated. And this is in hospital cardiac arrest. So again, initiating good ventilation is going to be critical from a physiologic standpoint early on, and that should be done as quickly as possible. In the out-of-hospital setting, we did a large randomized trial and found that there was no difference in outcome. Dr. Hansen and colleagues looked at CARES data, and they found that the odds of survival to hospital discharge for intratracheal intubation compared to BVM was 0.39, meaning it favored, essentially favored BVM. And then BVM overall was associated with higher survival. For a 15-year-old adolescent now who collapses on the football field after vigorous exercise, so physiologically normal, now suffers a cardiac arrest. They call 911. The coach on the field starts performing CPR, and you note that the patient basically is in ventricular fibrillation. So what do? You would initiate good CPR, including ventilations, and prepare to shock. And early shock is important. And so initiate first CPR and then approximately 90 seconds to 2 minutes initiating the defibrillation. So for shockable rhythms, I mentioned chest compressions, good ventilations, defibrillated at 2 to 4 joules per kilo. You do this for a couple of rounds after is it shockable? You would initiate the first shock and then epinephrine every 3 to 5 minutes. Initiate the second shock, consider amiodarone or lidocaine. And the third shock, you can consider up to 10 joules per kilo or whatever the monophasic or biphasic defibrillator initiates for adult patients. So consider up to 10 joules per kilo for initial shock resistant shockable rhythms. We mentioned the ventilation or the compression to ventilation ratio, which is for most resuscitations involving healthcare providers. 2 or more healthcare providers would be 15 to 2. If alone, it's 30 to 2, like the adult. And we mentioned the importance of getting good compressions with full recoil and avoiding excessive ventilation. Switching rescuers is going to be important, and everyone gets tired doing this. Typically, the mechanical compression devices do not work well with children. They're designed for adults. Although an adolescent of adult size, they could be used. In terms of shocking, and this is controversial in adults too, where do you place the pads? Typically with children, you can have them anteriorly placed, okay? One essentially over basically encompassing the heart as long as the pads don't touch in the middle. For most children, it's going to be front to back, so you can see the pad placement here. What about weight determination? Many of the gurneys now have the ability to determine weight in kilos, so that could be used. The other is the Broslow tape or any type of length-based resuscitation tape that has been updated could be used. And so, again, if the child's weight is unknown, you can use a length-based resuscitation tape. The H's and T's, I mentioned this before, some things that are problematic. Probably the biggest for children is going to be hypoxia and then hypovolemia. By far, those are the most common causes of pulseless electrical activity. At some point during the resuscitation, you can check glucose. That should not be an initial priority by any means because the likelihood that the cardiac arrest is caused by hypoglycemia is really low, except for certain toxic ingestions. But overall, you can get it later, but I would initiate good multiple rounds of chest compressions and ventilations and establish the goals of care. Capnography, I mentioned earlier, it's recommended to confirm endotracheal tube placement. So some of the adequacy of CPR. Also, it may help you determine when ROSC occurs with a sudden rise in end-tidal. But again, it's not used for termination of resuscitation in general. It's not recommended. The post-cardiac arrest syndrome is really important to recognize. And so supporting the child, oxygenation, ventilation, and perfusion post-cardiac arrest is critical. So you want to prevent secondary injury by supporting, as I said, oxygenation and and perfusion, typically with fluid resuscitation and also use of pressor agents, either intravenous epinephrine or push dose epinephrine could be used. So generally we want to target oxygenation 94 to 99%. We don't want hyperoxia. You would generally initiate 100% oxygen, supplemental oxygen, obviously with bag mask ventilation, and then that can be dialed down once the child has achieved ROSC. You also want to, I didn't mention hyper or hypothermia, but you definitely want to maintain normal thermia. And then ventilation, it's important that with hypercapnia, you can have cerebral vasodilatation and hyperemia. And so important to understand that. And also vasoconstriction with hypocapnia. So the bottom line is we want to target normal ventilation. For perfusion, hypotension occurs very commonly in about half of the cases after ROSC. So you really want to target in improving perfusion with both fluid resuscitation as well as with vasoactive infusions. And so, as you can see, many times the children do not receive that, and they should receive it early on. This is how to do push dose epinephrine. You take a 10 ml syringe filled with 9 mils of normal saline and then drop 1 mil of epinephrine, of the cardiac epinephrine. And you want to essentially mix that and infuse 1 mil at a time. You're delivering a concentration of 1 to 100,000, and you want to do it approximately 1 mil at a time, depending on the age of the patient. And then I mentioned temperature. The key is to maintain normothermia, and the goal would be to be between 36 and 37.5. I did not mention ECMO. ECMO, or extracorporeal cardiopulmonary resuscitation, can be considered with in-hospital cardiac arrest refractory to conventional CPR, really in selected populations. There's not good rules. Some have used this for things like near drowning, severe hypothermia, as well as post-cardiac arrest, or for myocarditis in some situations in cardiogenic shock. Finally, autopsies are recommended for young victims of cardiac arrest because it may identify inheritable problems such as channelopathies, prolonged QT syndrome that can affect their siblings or other family members. We do generally allow parents to remain during the CPR if indeed they wish to do so. We generally give them the option, and having some protocol for this, as well as assigning a person. It's going to be another healthcare provider, assigning someone to the family to explain what is going on is very helpful. So the chain of survival includes all of us, which is going to be not only as lay individuals for early recognition or early CPR, but us for advanced care, and then ultimately getting the patient to the right post-resuscitation care facility. And I'll go ahead and stop there and take questions. Thanks so much.
Thank you very much, Dr. Marianne. Question, please, you can send it to the question and answer box, please. And we will give you the answer soon once we have it. Okay, we are now having the most of the answer of the question that you have sent yesterday, and it will be now in the question and answer box. Um, Now, our next speaker will be Professor Mohsen Saidi Najat. He will talk about best practice imaging for pediatric trauma patient. Prof, you can start, please.
Hello, everybody, and welcome to this presentation entitled Best Practice Imaging for Pediatric Trauma Patient. My name is Dr. Saidi Najat. I'm a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I also serve as the executive director for translational science and population health at the Lundquist Institute for Biomedical Innovation at Harvard UCLA. I am funded by the Emergency Medical Services for Children Innovation and Improvement Center, which is supported by a grant from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. This grant totals $3 million with 0% finance from non-governmental sources. The contents of this presentation reflect my own opinions and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the US government. I wanted to go over the learning objectives for this session. This talk is going to go over the importance of judicious use of imaging in pediatric trauma. We also want to review some of the tools that are developed by the Pediatric Emergency Care Applied Research Network, also known as PCARN. And we also wanted to discuss approaches to specific risk assessment and target our imaging in blood trauma to exactly where it's needed. So some of the general considerations to make is obviously imaging is a necessary part of any trauma patient management if you wanted to get effective and timely care of a trauma patient. We also have to recognize that children are more sensitive to the effect of radiation than adults. They have a higher risk of getting more radiation over their lifetime because they have a longer life ahead of them. We also need to think about adjusting radiation dose whenever radiation is needed to the child based on their age and size. We want to focus our imaging on cases where it actually makes a difference in how we manage that patient. And we should always ensure that our clinical exam drives some of the decisions for doing imaging. It is important to recognize that cancer risk in children is something extremely important to consider. If you look, for example, at a girl who is younger than 5, who gets an abdominal or pelvis CT with IV contrast, for every 300 of these CTs that are done, we cause 1 case of solid tumor. Similarly, when we look at C-spine CT, for every 270 CT C-spine in a girl under 5, we cause 1 case of solid tumor. So this is not trivial. This is an important consideration to make. The dose of radiation has a lifetime cancer risk. So I was going to go over all of the different parts of the body when it comes to multisystem trauma. We're going to go over head, C-spine, thorax, abdomen, pelvis. So I'm going to start with the head. Trauma head imaging has really great evidence behind it. PCARN decision tool for trauma is actually very good and is widely practiced throughout the United States and many parts of the world. And we know that many of the children who have trauma have an isolated head trauma where they may not need anything other than imaging of their head. In terms of head injury, while head injury is very common, almost 600,000 to 800,000 visits to the emergency department in the US each year are for a head injury. But the number of head injuries that result in a traumatic brain injury is extremely low, less than 0.9%. Even of the patients that we do a head CT, less than 10% of those head CTs reveal anything at all. So this is one of those decision tools from PCARN that we actually repeated through our work that I do at EMS for Children program. This is for under 2. So if you can see for a head injury, a child who's under 2, there's really only 3 reasons to automatically do a CT. One is when the GCS is less than 15, one if there is any signs of skull fracture, and one is if there is altered mental status. Other than that, where the risk would be 4.3% if any of those 3 were present, you have option of doing CT or observing. So that middle box, scalp hematoma, loss of consciousness greater than 5 seconds, height of fall, mechanism, those are all the things where you can decide either to observe 4 to 6 hours or do a head CT. And who you observe and who you do a CT really depends on your clinical decision. If you see in the bottom right, this is the clinical features that you can use to decide if you're going to do a CT or you're going to observe. If it doesn't have any of those in the intermediate box, then you don't need any imaging. You can just clear them for discharge. Similar thing for the over 2 years. The only difference there is that for over 2 years, vomiting, severe headache, fall is greater than 5 feet. But other than that, it's pretty much the same exact thing for over 2-year-old. The only other consideration is that in the under 2, hematoma of the scalp was, as you can see here, the first item here, any hematoma other than frontal. But when you go to the greater 2-year-old, that's not included. So if you're trying to consider a hematoma of the scalp, PCARN decision tool only considers that appropriate to consider on the children under 2. So here's an example. A 7-year-old female brought to the ER by EMS, ran into a pole during PE class. They had a brief loss of consciousness, GCS is 15. They have a occipital hematoma, and they had 1 episode of vomiting during transport. So what's the best approach? So if you can see here, LOC doesn't meet the criteria. It's less than 5 seconds. GCS is normal. The hematoma doesn't matter because age is greater than 2. So the only thing she has is that 1 episode of emesis. So that puts an intermediate group. If you want to go ahead and observe, you can observe this person 4 to 6 hours just because of that vomiting. Other than that, you can consider CT if there's other findings. So this case is a simple case of observing. Now let's go to C-spine. C-spine is a little bit more tricky. There is more than 8 million children evaluated each year for C-spine injury. That includes all the kids with torticollis. And less than 1% of them really end up having anything at all. The incidence of C-spine trauma is extremely low, almost 4 in a million. And of those, half of those are C-spine. Also important to realize that children under 8, they're more likely to have upper C-spine injuries, C1, C2 axial. And greater than 8, they start having more like adult pattern, which is subaxial, C3 to C7 injuries. And at present, almost all of the C-spine imaging is just a CT. And we know that a single CT of cervical spine can increase childhood risk of lifetime thyroid cancer by 78%. So it would be really nice to have a way to decrease the number of CTs we get for C-spine. For this, there is some arguments already that we might be able to just do an X-ray as opposed to a CT in some cases. The American Academy of Pediatrics recognizes that the incidence of C-spine injury in pediatric patients is very low, and plain films are actually pretty sensitive for detecting fractures in a C-spine. And advanced imagings can be basically reserved for when the C-spine X-rays are inconclusive or a clinical scenario suggests we should do more. And the same thing with American College of Radiology. They feel that radiograph plain X-ray is almost 90% sensitive. It is not as good for soft tissue and ligamentous injury, but if you're worried about bony injury, that's actually very good. There's a study also done before the PCARN major study that looked at C-spine, looking at who would potentially need a C-spine CT. Those who you cannot clear without imaging and those who you cannot do an X-ray. So the patients who have focal neurologic deficit, they probably have a more significant injury, probably need a CT C-spine. Those who have axial loading injury, like a diving mechanism, they have a 73-1 odds of having a significant C-spine injury. And the third group is the ones that have predisposing factors such as atlantoaxial instability, patients who have Down syndrome or any kind of ligamentous laxity like Ehlers-Danlos, or those kind of patients also probably cannot be just given a plain X-ray. But the majority of others, probably we can do an X-ray. So this is the C-spine decision tool for PCARN. The high-risk patients are the ones who have a GCS really low, 3 to 8, who are unresponsive on the AVPU scale, which is alert, verbal, response to pain, unresponsive. They have to be U, unresponsive. Those who have abnormal airways, those who have focal neurologic deficits, they get a CT C-spine. If you have none of those, you can still have altered mental status with a GCS that's greater than 8. You have neck pain, range of motion problems, or substantial head and neck injury, then you can start with the X-ray C-spine. And if there's anything in there that is not conclusive, then you can do a CT. I have to say that our trauma surgeons at my facility, they are not happy just doing a lateral C-spine X-ray for substantial head and neck injury and torso injury. They definitely will do a CT. But this PCARN decision support really puts them in an intermediate group where a CT is not required as a starting point. And if you have none of those, you basically need nothing. This is the little pocket card version of the C-spine tool with the color coordinated who gets CT, who gets X-ray, who gets nothing. Again, as you can see here, the prediction rule for PCARN C-spine is very good, has a almost 95% sensitivity, almost 100% negative predictive value, and it is resulting in at least 50% reduction of C-spine CTs without really losing any information. So if you look at this case, for example, a 12-year-old male comes to the ED after falling from an e-bike. GCS is 15, no loss of consciousness, but he's having trouble moving his neck. He has no focal neurologic deficits, no other issues. What is best? So the only thing he has is trouble moving his neck. So if you look here in the intermediate group, any kind of self-reported neck pain, tenderness, or exam, this is intermediate, and we can probably get a C-spine X-ray on him and proceed from there. If there's any abnormalities on that, then we can consider further imaging, but this is a patient that can just get the get the X-ray C-spine. Now moving to thoracic imaging and trauma. Thoracic imaging accounts for 4 to 8% of all pediatric trauma cases that are thorax only. Most of the thoracic injuries are in combination with other injuries. Mortality level from pediatric thoracic trauma is very high, actually, 6 to 20%. And it's even higher when it's part of a multi-system trauma. The majority of pediatric thoracic traumas are blunt traumas from a vehicle collision, from a pedestrian accidents, and falls. With children, their rib cage is very compliant and elastic, so they're more likely to get pulmonary contusions and less likely to get rib fractures. But if they get rib fractures, that doesn't necessarily correlate with the underlying pulmonary contusion. So if the chest X-ray doesn't show anything like mediastinum that's widened or patient is not hemodynamically unstable, it's probably nothing significant. So while PCARN doesn't actually have a specific tool for thoracic imaging, but PCARN does advocate for starting with a plain chest X-ray, and most of the times that would work. If there's anything abnormal, or you cannot exclude other injuries from the chest X-ray, you can expect more imaging. You would consider thoracic CT mostly in the cases where abnormal radiographs are present, you have a suspicion of vascular injury. Maybe other thing that you should recognize is that widened mediastinum should not be confused with the smaller age children who have a thymic shadow. This is our algorithm that we created at the EMS for Children program. Again, this is high energy mechanism with blunt mechanism, direct blunt trauma. You start with a chest X-ray. If it's normal on the mediastinum, everything looks good. Look for other injuries, rib fractures, sternal fractures, pneumothorax, and deal with them as you see them. If they are abnormalities on the mediastinum, then you should get IV contrast and prepare for trauma surgery. And if you have any abnormalities on the chest X-ray, like rib fractures, sternal fractures, scapular fractures, then you can get a pericardial ultrasound. If the pericardial ultrasound is abnormal, then you might get a CT. Otherwise, if it's normal, you don't have to do anything further. So look at this case. There's a 10-year-old male which was riding his bike when he was struck by a car going about 25 miles an hour, no loss of consciousness. His GCS is 15. He has contusions and bruises on his lower extremities, small abrasion over his right upper chest wall. He says he has pain with deep inspiration. Lung exam is normal. Pain, when you do a plain X-ray, you find a few right-sided pulmonary contusions. So what's the next step? So again, if this bruising was lower to the abdomen, then you have to also consider abdominal. But in the chest, if this patient just has contusions that are in the upper chest, they do not really require anything further other than perhaps a cardiac ultrasound to see if there's any pericardial effusion or anything like that in addition to those pulmonary contusions. So the information from the X-ray here was sufficient, right? The only thing you don't have is whether or not there's any pericardial injuries where you can do that with the ultrasound. And anything that you found is not going to change your management. And you can just decide whether this patient should be observed or in the hospital, or they can go home. And they have no other abnormal lung findings. So when it comes to the thorax, you're pretty much done. Now let's look at abdomen and pelvis imaging in trauma. Most of the abdominal injuries are blunt trauma. They account for only 5 to 10% of all pediatric blunt traumas. And the mechanism is just like the other trauma cases, either a motor vehicle collision or a fall. In children under 4, you have to consider non-accidental trauma every time that you see a blunt abdominal trauma that's not specifically explainable from a car accident or something like that. In terms of what organs get injured most often, liver and spleen account for 30% of organs that are injured in a abdominal trauma. Intestine and kidneys account for the other 20%. And usually to detect injury, the gold standard imaging strategy is the CT with IV contrast. But as I have been saying, this is a big dose of radiation. The question is, who can we spare this additional radiation from? So things to consider, we can do abdominal labs, urinalysis for kidney injury, hemoglobin for spleen injury, AST, ALT for liver injury, lipase for pancreatic injury. We can do a focused abdominal sonography for trauma, looking for any fluid around the pelvis, in between the liver and spleen, between the liver and kidney, liver and spleen, and to detect whether or not any extravasation of fluid is noted. You can also look at whether or not any coexisting injury exists. But one thing that I wanted to mention is that the trauma decision tool for abdomen pelvis that PCARN put out, although it's been available since 2007, it is not as widely practiced as the others. There's a lot of disagreements on what recommendations it has made. So reason being that this decision tool focuses on identifying low-risk groups. So it only looks at when CT can actually cause an intervention. For example, a liver laceration is just observation. You keep them in the hospital, observe them, you don't do anything with them. So it's not really meant to detect liver laceration, but it does detect cases where a transfusion may be needed, embolectomy may be needed for massive blood loss. So that's why it's not very commonly agreed upon. It also does not consider non-accidental trauma, which you always have to think of in smaller children. This is what it looks like the abdominal decision tool for PCARN. So when you do a CT for sure is if you have evidence of abdominal wall trauma, like a seatbelt sign or a contusion on the abdomen, if your GCS score is less than 14, then you have a 5.7% risk of an intra-abdominal injury that requires intervention. They strongly feel that a CT is needed. But if you don't have that and you have abdominal tenderness, which is moderate or severe, then you have a 1.4% risk of intra-abdominal injury that requires intervention, and that's a CT versus observation. And if you look at the right lower area, physician experience, multiple versus isolated findings, fast laboratory scans, those are things you use to decide if you're going to CT them or not. So you might just do all your abdominal labs, do your fast, watch them for a little bit and decide whether they're getting better or they need a CT. And then obviously if they have thoracic wall trauma, abdominal pain, decreased breath sounds, vomiting, abdominal tenderness, they're on the 0.7% risk, and that is mostly observation. If you have none of those, then you don't need anything. This is again another way of displaying this. This is what our team developed. So when you look at the labs, for example, any AST greater than 200, ALT greater than 125, abnormal lipase, low hemoglobin, abnormal chest X-ray, and gross hematuria, those might be things to help you decide whether you're going to do a CT, abdomen, pelvis, or observation for admission and serial examination. This part here in the middle is what we added to it because PCARN doesn't really give these guidelines for somebody who will get a CT based on lab results. These are the labs that we're going to use. So case, if the 16-year-old female was restrained front seat passenger in a car that was in a crash at an unknown speed, hitting a parked car. There was an airbag deployed, no LOC, GCS is 15. They have pain in the upper abdomen. Seatbelt sign is not present. No mild tenderness is noted. Thoracic trauma is not present. No vomiting. So for this one, if you look at the decision support, so they don't have any abdominal trauma signs. GCS is okay. And they don't have that higher risk so that there's not an automatic CT. Then you go here to tenderness. It doesn't say whether the tenderness is moderate or severe, or the patient says it hurts. So at best, this is a yes here that takes you to CT versus obs, or you can just go down to abdominal pain here that the patient states, and that makes it observation. So anyway, between second and third choice of abdominal CT versus observation or observation alone, you can use your labs, your experience, parental preference, fast ultrasound to decide if you're going to move on to a CT or just continue with observation. Majority of just cases, they end up being able to be observed, and that way you're going to reduce the radiation risk because you are actually thinking about the CT rather than just starting with one. So I put that in here because we do have great variation around us, and I know at my institution we do a lot more CTs than we like. And I just wonder if your institutions, you're doing PCARN abdominal decision tool or not, and how often do you have an alternative to do abdominal CT in trauma? Because again, the dose of radiation is very significant. Our trauma surgeons at my hospital feel that our patient population has a high rate of significant injuries, and that is why they do a lot more CTs, because everybody is a critical case. Nobody is easy. And also, our institution really cares about things like liver laceration and things that they would like to observe, although PCARN does not consider that interventionable, so therefore they don't consider that as must-do CT. Now, just a couple of quick cases, multi-system trauma. One of them is a 14-year-old female in a car that was going very high, 80 miles an hour. That is roughly 130 to 140 kilometers per hour. And they were not wearing their seatbelt. Driver lost control. The car rolled over 3 times, but the patient remained in the car. They're not sure how long they lost consciousness, but they were found walking around on the scene. They're awake. Their vitals look okay. They just complain that their jaw hurts. They can fully open their mouth. There's no swelling, bruising, or marks, but they can open the jaw, but they say it hurts. So what is the best imaging? So if you look at head, the questionable LOC it potentially be an observation versus CT. There was nothing on the neck, nothing on the thorax, nothing on the abdomen. So I would say the only um, imaging we would do on that one was going to be the head, maybe, or observe for the 4 to 6 hours. Second case is a 1-year-old male who was being held by mom when a car they were traveling in was T-boned, meaning hit at a 90-degree angle to their car that was going about 35 miles an hour, and I think that's about 60 or so kilometers per hour. And as they were making a left turn, patient noted to have a laceration over their frontal scalp, sorry for the misspelling of scalp, and a boggy 4 centimeter hematoma over their occipital scalp. LOC is not known. They're crying, irritable. You see their vitals there. Their GCS is 13. They have blood in the mouth, seems to be from a tongue laceration. So what do you do here? Now here you have a little bit of a different situation. First of all, you have a 1-year-old who was having a hematoma of the occiput. Again, PCARN uses under 2-year-old, gives it a point for hematoma of the scalp. The patient also has a GCS that's only 13, so they definitely get a head CT. Now, whether they get a C-spine CT or not, there is a consideration here that in some of the institutions like ours, when we do the brain CT, we just extend the CT down to C3 because a 1-year-old is most likely to have the axial type of injury, which is C1, C2. So if we take the head CT and bring it down to C3, then you have the C-spine included pretty much in there. For thorax, again, as I mentioned, there isn't really any indication to start with a CT thorax, so we can do a chest X-ray. However, again, with the GCS of 13 here, which is GCS less than 14, you fall into the must-do CT for abdomen. So this patient gets a head CT with an extension down to C3. They get a chest X-ray, they get all the abdominal labs, and they get abdominal pelvis CT. So this one is a sicker patient, most likely going to be admitted, most likely is going to have findings. And yeah, the question of why they were being held and not be in their car seat. So that is something that a social worker has to kind of address because we want to resolve this before they're allowed to go home. And that's it. Thank you again so much for allowing me to speak with you today about trauma imaging. I'm sorry that we couldn't be there in person given the circumstances. Sorry about the Zoom, but hopefully next time I will get to be there with you and present in person. And this is a picture from my neighborhood in California. Wishing you all the best. And again, thank you so much for listening to this presentation.
Thank you, Dr. Mohsen, for your lectures about the best practice imaging for pediatric trauma patients. And now let's go to the next lectures with Dr. Todd Chang about 2025-2026 about pediatric emergency medicine literature review that can change your practice. Welcome, Dr. Todd.
Hello, everybody. My name's Todd Chang. I'm faculty at Children's Hospital Los Angeles in California in the United States. This is going to be a fun lecture. I found a few articles that are fairly large that may or may not change the way you practice pediatric emergency medicine, and I just want to dive right in. The objectives are pretty simple, and we're going to find several key research studies. The first one is going to be on anaphylaxis treatment innovations. This is a review article that I found from Japan, Takashi and al. In 2025 that really looked at intranasal adrenaline or intranasal epinephrine. So instead of intramuscular epinephrine, there's a growing trend towards using intranasal medications for rescue. And this is also the same with intranasal medications for seizure management that you'll hear about later. An example of one is in the brand name of Neffy on the left-hand side. There's a 2 milligram version and a 1 milligram version. The higher dose is for the older kids, 30 kilograms and higher. The 1 milligrams is for the 15 to 20 milligrams. And there's different brands that do intranasal adrenaline or intranasal epinephrine. The proponents of using intranasal adrenaline are the fear and anxiety and the complexity of doing an auto-injector at home from potentially untrained family members or even an untrained child. Intranasal adrenaline or epinephrine has no needle, and it should be relatively simple to administer. The time to maximum concentration is otherwise reasonably similar to auto-injectors. What we know from the literature review is that the IN intranasal versions have comparable pharmacodynamic properties with IM or intramuscular versions, and repeated use if necessary when the intranasal route actually has higher absorption than repeated intramuscular injections when they tested it in healthy adults. For those of you who are wondering what happens with congestion or nasal infections, absorption of intranasal epinephrine or adrenaline is actually better than without nasal congestion, whether it's congestion due to the anaphylaxis itself or because they have a concomitant upper respiratory infection. It actually doesn't matter. The absorption is better. And any adverse events from the increased absorption were mild. They're present, but mild and not systemic. So this gives me pause in thinking about instead of injections, especially for families who are not particularly fond of injections, this may be an intranasal epinephrine or intranasal adrenaline may be an excellent alternative. Okay, we're going to switch to DKA, diabetic ketoacidosis management, and here's an article from 2025 from Bonsall. And we're going to look at the effect of insulin glargine, the long-acting insulin subcutaneous injection during early management when DKA is being treated. This was a study in one hospital that was double-blind randomized controlled trial enrolling 82 children at one single center in India. They were aged 1 month to 12 years of age. The randomized intervention group received insulin glargine subcutaneous at about 0.3 units per kilo, and the control group also got a subcutaneous injection with just saline. They had several outcomes that they measured, but the first primary outcome was time to DKA resolution in hours. And then finally, they also looked at adverse electrolyte events, either hypoglycemia because of the glargine or hypokalemia, treatment failure, which is defined as failure to lower the blood sugar at least to 18 milligrams per deciliter an hour, or severe acidosis, or if the clinical team felt that the insulin had to increase to 0.2 units per kilo an hour from 0.1. And then finally, they looked at rebound hyperglycemia once the insulin drips was stopped, and they moved on to regular subcutaneous insulin. They found that there was no significant difference between glargine and placebo in the time to DKA resolution. However, there was a substantial decrease in incidence of hypoglycemia and rebound hyperglycemia, as well as lower treatment failures in the glargine group. Sorry, I'm covering up the p-value on that side. So what this means is that adding subcutaneous insulin glargine, about 0.3 units per kilo, while in the active phase of DKA, does not seem to increase or decrease resolution time, but does improve odds of improve treatment failure or rebound hyperglycemia in terms of better outcomes. It does not seem to increase side effects while it's doing that. So you may actually see endocrinologists or yourself starting insulin glargine on top of your insulin drips with patients in DKA. All right, so let's talk about pediatric sepsis. Here's some updated guidelines in the 2026 Surviving Sepsis Campaign International Guidelines. We actually have quite a few people who already have done lots of work on sepsis guidelines for children with multiple years, with the last updates from this group in 2020. And so this article simply goes over the different changes that they've made for 2026, and I'm just going to highlight a few here. In the Surviving Sepsis campaign, they looked at 61 recommendations, some of which were up for review in 2026, and they had an international panel review all the literature involved with the recommendations that were up for the 2026 review. Here's some of the key points. In 2026, we now add and recommend blood lactate or lactic acid levels as part of the initial evaluation and management that continues into the critical care realm. In the 2020 guidelines, lactate was suggested, but it was not particularly recommended. But current literature actually supports the use of lactate to be able to custom tailor the prognostication and the treatments. Number two, there's insufficient evidence to implement the routine systematic sepsis screening. So these are going to be sepsis alerts from your electronic medical records. These may be different routine overall sepsis screenings for all patients. What they do recommend instead is to simply have clinical pathways to identify them, but there's no special recommendation for you to implement a house-wide or hospital-wide screening system. Because molecular testing is relatively new, there's insufficient evidence to say yes or no for molecular testing for bacteria, but blood cultures are still recommended. And of the inflammatory markers, procalcitonin is not routinely recommended to guide any escalation of treatment. For those children with central lines, there's now a targeted SCVO2 level that's preferred. We now have POCUS as a possibility to guide resuscitations. There is no set threshold on when to start vasoactive pressors, so 40 mLs per kilo has been used before, and they now say that there's insufficient evidence to recommend it right at that cut point. And there's also insufficient evidence between choosing norepinephrine versus epinephrine. We now know that epinephrine or norepinephrine is preferred over dopamine. But between the two, norepinephrine or epinephrine, there's insufficient evidence to routinely suggest one always over the other. So it's clinical discretion advised. Additional topics include inodilators, angiotensin II, methylene blue, and sodium bicarbonate. Sorry for them spelling. So these are case-by-case basis. There's no evidence to suggest a routine use for any of these. There is a new target set for oxygen saturations of 88 to 92%. That's preferred over a more liberalized oxygenation status if the patient is intubated. And then finally, there's insufficient evidence for or against routine IV hydrocortisone unless there is a strong suspicion for adrenal insufficiency. The 2020 guidelines actually had a much more liberal recommendation for the use of hydrocortisone, and the 2026 recommendations back it up a little bit so that it's probably not necessary unless you have adrenal insufficiency. Great. Okay, moving on from sepsis to appendicitis. Here's the study. This is a multi-center study across multiple countries, actually, on appendectomy or appendicectomy versus just antibiotics for acute, uncomplicated, unperforated appendicitis in children. This is an unblinded, randomized controlled trial. They enrolled a total of 936 patients with a fair amount of attrition. These were children 5 to 16 years of age amongst 6 different countries that were participating with non-perforated appendicitis, and the one group had IV antibiotics, which was IV antibiotics per hospital guidelines, and then when tolerating POs and tolerating oral, then they went home with either amoxicillin clavulanate or ciprofloxacin and metronidazole. The control group had the typical gold standard of appendectomy in less than 12 hours of admission. And they measured treatment failure within 1 year. And these are the two different definitions of treatment failure. Adverse complications and hospital length of stay. Note that for the IV antibiotics team, treatment failure means any appendectomy within 1 year. The control group treatment failure is if the appendectomy was done with a normal appendix, so negative appendectomy, or if there was a surgical complication within 1 year. Overall, the treatment failure percentage for appendectomy patients was approximately 7%, with only one patient in this entire group requiring some level of complication management after surgery. After surgery requiring further surgery. In the antibiotic side, the failure of antibiotic treatment requiring appendectomy within the first round of antibiotics was fairly high, 72 out of 452, which calculates to about 16% failure rate. And then for those patients who had antibiotics, got better, and returned back to normal, 81 of those, or 18%, came back with a subsequent need for with concerns for appendicitis and had an appendectomy. When you look at the secondary data, including daily diary data, which you see the ends is much lower, the antibiotics groups had a much faster recovery back to school and much fewer days taking pain medications. So essentially, antibiotics is available. It's IV and then oral for pediatric appendicitis. It does have a higher treatment failure as defined with an appendectomy anytime in the first year, between 16 to 18%. But it does result in faster return to normal when they do return to normal.
هو لا لا خليه
Our favorite disease, bronchiolitis.
الأزرق ها
Let's go.
الرصاصي ما له علاقة بس
So this is a position statement from Predict. Predict is the Pediatric Emergency Research Network within Australia and New Zealand, in that area of the world. And this was essentially an expert consensus systematic review with 41 recommendations that were done in 2016 that were all reviewed for 2025. Out of these, 431 articles were pulled to answer questions about 41 recommendations. There's about 11 new recommendations, some of which are not applicable to the emergency department, and 7 key updates since 2016. So I'm just going to go over some of them. Number 1 was that bronchiolitis can present with also dehydration, diarrhea, and apnea as a primary physical exam finding or history, as opposed to the purely respiratory. They've added additional risk factors for consideration for increased level of care or admission. This includes economic disadvantage, genetic or lung issues like trisomy 21 or congenital diaphragmatic hernia, and tobacco smoke exposure also increases risk. It used to be in 2016 that they recommended routine urine testing for febrile bronchiolitis patients, but that is no longer recommended. Essentially, it's clinical discretion. They also recommend for those who are admitted and discharged for bronchiolitis that patients have local follow-up and education with the families to decrease the amount of patients we need to come back. Number 5, ICU level patients, so patients who need critical care, might be good candidates for either a steroid glucocorticoid or epinephrine, racemic epinephrine, while its routine use is not recommended for mild to moderate bronchiolitis. We have now lowered the oxygen saturations to 90% instead of 92. 92% is still used for infants under 6 weeks of age or those with comorbidities. And the group also now has some recommendations on fluid restrictions, so calculating to approximately 50 to 75% maintenance. And that's actually considered for the risk of SIADH, syndrome of inappropriate antidiuretic hormone, and hyponatremia. A couple of other interesting tidbits for us. There's a position for nasogastric or NG tube feeding rather than IV hydration as first line. They also now recommend low flow oxygen to prevent every single child to go into high flow immediately. And high flow nasal cannula patients can still have enteral feeding using standard fluid restrictions at 50 to 75%. And then now that COVID is around, for those patients with suspected bronchiolitis, routine SARS-CoV testing is not necessarily recommended just to find out what they are. But if your hospital tests for SARS-CoV for anyway and you find out that they are positive, there is a possibility that dexamethasone or remdesivir may be indicated. That's clinical discretion advised. Awesome. A couple more. Let's talk about procedural sedation. In this particular article looks at the optimal intranasal midazolam dose for procedural sedation. And in this particular group, they looked at specifically laceration repair required intranasal midazolam. This is an adaptive double-blind randomized controlled trial with a total enrollment of 101. Adaptive meaning they started with all 4 doses, and if there's any doses that are not having sufficient sedation, that arm got knocked off of the study. So the children 6 months to 7 years with lacerations, and the clinician decided to use intranasal midazolam. They were randomized to one of 4 doses, 0.2 to 0.5 mg per kilo with a maximum of 10 milligrams, and they measured the pediatric sedation state scale of whether it's appropriate or not, 0 to 5, and secondary outcomes of time of onset and time to recovery. Because it was an adaptive trial, they found out pretty quickly that 0.2 and 0.3 milligrams, the low doses of 0.2 and 0.3 milligrams per kilo, were actually inferior to the higher doses for appropriate sedation. Therefore, they reported data only on the higher doses, 0.4 and 0.5. When we look at them, the ideal sedation state had no difference between 0.4 and 0.5. The onset of sedation was similar, adverse events were similar, and satisfaction by the clinicians and caregivers or parents were also similar between these 2 doses. So higher doses, 0.4 to 0.5 milligrams per kilo, of intranasal midazolam has improved procedural sedation for lacerations than lower doses without increasing adverse events. All right, a couple more. Let's do febrile neonates. That's our bread and butter, of course. Bread and butter meaning that this is the kind of patient that we tend to see all the time. And this is a validation of the PCARN febrile infant rules for serious bacteremia. And we're concentrating on ages 28 days or younger, so 4 weeks and younger. This is a pooled data set from 6 different countries in the PER network, the Pediatric Emergency Research Network, that we talked about multiple different countries of databases and researchers for a total of 1,537 patient data. These were full-term healthy infants, less than 28 days of age, and they had a documented fever 38.0 Celsius, and there was testing involved, some sort of blood, urine, or CSF. The exposure group is classified as low risk using the PCARN rules of negative urinalysis, a serum procalcitonin of less than 0.5 nanograms per milliliter, and a blood absolute neutrophil count, ANC, of less than 4,000. If any of these were positive, then you were automatically classified as high risk, and we looked at the incidence of invasive bacterial infection, whether it's bacteremia or meningitis. In this data set, approximately 69 of them, 4.5%, had invasive bacterial infections ranging from 2.5 to 7.3% in different countries. Of them, most of them were bacteremia alone, 3.8%, and 0.7% was the rate for bacterial meningitis with or without bacteremia. Of these, about 1,080 of these kids did have CSF cultures available. That's 70%. And the other 30% who did not have CSF cultures did not have any bacterial meningitis upon follow-up. When the PCARN criteria was used to classify low risk, approximately 632 or 41.1% were classified as low risk. This resulted in what you'll see here with sensitivity is 94%, specificity 41%, and a ppV of 6.9. The specificity and sensitivity are for any bacterial infection. Looking back, the PCARN criteria did miss 4 of the 69 infants with invasive bacterial infections. All 4 of them were bacteremia, and there's no missed meningitis. And in fact, if we did an MPV for bacterial meningitis, not just bacteremia, among all cohorts, it was actually greater than 99.96%. So the PCARN febrile infant rule had, for low-risk infants, had high sensitivity and limited but acceptable specificity for ruling out invasive bacterial infections. This rule is definitely better for not missing bacterial meningitis among febrile infants less than 28 days old. And so there is a potential that in our near future, we will stop doing lumbar punctures in some of these infants less than 28 days. Finally, a little overview on pediatric resuscitation science. And this comes from a joint report from the American Heart Association and many other areas on the 2025 ILCOR guidelines. So they do 5-year updates, the International Liaison Committee on Resuscitation, and for PALS, Pediatric Advanced Life Support, they have several recommendations that have changed since 2020. The first is actually fairly big for bradycardia patients. Children with bradycardia and hemodynamic compromise not responsive to oxygenation and ventilation should be initiating CPR, and that's been that way for quite some time in the recommendations. However, now in 2025, there is no longer any recommendations for epinephrine, atropine, or pacing in bradycardia patients with hemodynamic compromise. This is because there has not really been shown any effect and limited evidence for these 3 treatments for children with bradycardia, whereas CPR has been shown to have an effect. There's also a statement now on the order of resuscitation. As you may know, that for adults, it's CAB, chest compressions, and then airway and breathing, versus ABC in children. And there's actually insufficient evidence. There's lots of evidence of people doing CAB versus ABC, but there's no evidence to suggest one over the other. For those who intubate during resuscitations, the out-of-hospital cardiac arrest should be managed with bag valve mask ventilation because it has not been shown to improve with advanced airways. There is insufficient evidence for delaying intubation for in-hospital cardiac arrest. So as long as the chest compressions are going, it may be a useful adjunct. For defibrillation, for those of you who have been around since 2005, there was a phenomenon called stacked shocking. That's when you do 3 different defibrillations, bam, 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 before you start CPR. So we finally have an official recommendation that a single shock followed by immediate CPR is recommended over the stacked shock recommendation from 2005. So if you're going to shock, go ahead and do so, but then immediately follow with CPR. There's evidence to show that coronary perfusion is necessary after the shock, which is only done with CPR. If there's invasive monitoring in your unit, then you can target CPR with targeted blood pressures with a diastolic of 25 or greater for infants less than 1 year of age and 30 and greater for everyone else. For end titles, end tidal monitoring can be used and is recommended during a code or cardiac arrest, but it should not be used to have a cutoff for termination of CPR. For eCPR, ECMO, extracorporeal membranous support for cardiac arrest, it should be considered or may be considered for cardiac arrest children who have single ventricle physiology because CPR or chest compressions may be insufficient for them. Or the more ideal patient might be an in-hospital arrest refractory to conventional CPR. It is not recommended to do ECPR if the resources are low or if there's a prolonged out-of-hospital cardiac arrest. And then for those of us who are in the post-resuscitation critical care world, following return to spontaneous circulation, mean arterial blood pressure should be greater than 10th percentile for age. Invasive monitoring will be very useful for that. So those are some of my favorite articles. If you have any questions, please write. Thank you very much.
Thanks a lot, Dr. Todd, for your lecture about the pediatric emergency literature review. And now we'll go to the next lecture about global pediatric readiness initiatives by Dr. Mariana Kochi-Hill. Welcome, Dr. Mariana.
Hi there, my name is Dr. Marianne Gauchi-Hill. I'm an emergency physician at Harbor UCLA Medical Center in Torrance, California, and professor emeritus of clinical emergency medicine and pediatrics at the David Geffen School of Medicine. And I'll be speaking to you today on global pediatric readiness initiatives. So let's go ahead and get started. First of all, I have nothing to declare. I am a senior consultant for the EMS for Children. We're going to talk about some global initiatives. First of all, in the U.S., children account for about 5 to 10% of all of EMS or emergency department visits. And really, ultimately, there's limited experience for paramedics, nurses, and physicians caring for sick kids, either with critical illness or injury. When we look at the 27 million emergency department visits for children in the U.S., less than 2% require any type of tertiary care or critical care. And ultimately, the average ED sees fewer than 10 children a day, which leads to this experience gap in terms of for any practitioner in caring for critically ill or injured children. And because of this, children are not on a hospital's radar on a day-to-day basis, meaning for quality improvement, initiating, as an example, tracer methodology or other quality improvement metrics to look at care of children. What we have found over the years is that assigning the role of a pediatric emergency care coordinator or someone who can help direct resources for the care of children in the ED. If that does not happen, then readiness will wane, meaning the ED won't continue efforts to be prepared for the care of children. We know this is important in the United States for a number of reasons. One is about 66% of families are greater than 30 minutes from an emergency department fully prepared to care for kids. And when we talk about preparedness, what we're talking about is fully compliant with national guidelines that have been approved by greater than 20 organizations in the United States to care for kids. So guidelines for the care of children in emergency departments, essentially. The other data piece that we know is that if a child dies, the average time to death is relatively short, and thus emergency care is going to be critical in terms of saving these kids and early resuscitation. The pediatric emergency care in the U.S. is really the perfect storm. So what do I mean by that? There's an increasing number of pediatric emergency department visits, but yet reduced inpatient capability of hospitals. And in fact, we know that about somewhere between 20 and 30% of all inpatient pediatric beds were gone after COVID. So many of those resources during COVID were redeployed to care for children, meaning not only clinician resources, but also inpatient beds. There's an increasing number of transfers to pediatric regional centers, and so they need to have the inpatient capacity to be able to absorb the number of children that need to be transferred from emergency departments. And it really highlights the fact that EDs need to be able to care for these, not only resuscitate, but be able to care for these children prior to transfer to a regional center. And in fact, this really was exemplified in the triple-demic, we call it. And this is after COVID, the spike of RSV, or respiratory syncytial virus, influenza, and COVID that occurred, where many EDs had to manage these patients with high-flow nasal cannula in their ED for days at a time. What we have seen overall in the US is a loss of greater than 1,000 pediatric beds, and indeed even a reduction in the number of hospitals, somewhere between 2 and 3%, who have pediatric ICU capability. So what is pediatric readiness overall? And, it's a great question because the pediatric readiness efforts have been somewhat focal in the United States as compared to the rest of the world. But I believe, and we're going to talk about global pediatric readiness, it's really increasing in terms of the interest on a worldwide level. Pediatric readiness in the U.S. means that an ED has the processes, staff, equipment to treat children. And really, it's a commitment by the hospital to comply with national, state, and regional guidelines for pediatric readiness. And it's really through different types of changes, not only structural process changes, administrative changes that promote pediatric quality of care. The other realization, and I think this has been borne out in a number of man-made as well as natural disasters, and that is improving day-to-day readiness improves disaster readiness. In the United States, the Pediatric Readiness Effort and the National Pediatric Readiness Project, which now encompasses both preparedness in EDs and preparedness in emergency medical services systems, or the pre-hospital setting. The main sponsors for the initial program and continues all to sponsor the National PEDS Ready Project are the American College of Emergency Physicians, American Academy of Pediatrics, Emergency Nurses Association, the EMS for Children program, which is federally funded, and then the American College of Surgeons, specifically the traumatologists or the Committee on Trauma. There have been 4 versions of these national guidelines, initially co-sponsored by ACEP and AAP in 2001, and now the latest rendition in 2026, basically authored by ACEP, AAP, ENA, and now ACS. As I mentioned, there are pre-hospital guidelines. Those were published in 2020 with a huge number of pre-hospital stakeholders as well. I'm going to really focus the balance of my comments on emergency department versus pre-hospital, but both are very important. In terms of national assessment, the first was done in 2003 by myself and colleagues who reached out to all the EDs in the United States to understand whether or not they were compliant with national guidelines. About 30% responded in that large paper assessment. In 2013, we launched the first web-based assessment, and 83% of EDs in the United States responded with a score. We call it the Weighted Pediatric Readiness Score, which is a score that was determined by national experts based on the guidelines from 0 to 100 to measure the pediatric readiness of that hospital. And the score was 69. And then in 2021, during COVID, we had 71% of EDs responding, and the score was 70. We have continued to improve, which I think is important. And what we saw in 2021 was that literally every domain, at least 5 of the 6 domains, went fairly substantially from the last assessment, meaning 97% of the EDs have 97% of the average ED has 97% of the recommended equipment, which is awesome. We also saw a big increase in pediatric mental health care policies for the ED. Weighing in kilos went up, and competency evaluations in terms of in the care of children went up. We also saw some increase in quality improvement plans, although those are generally driven by the pediatric emergency care coordinators, who are a physician and a nurse assigned the role of pediatric readiness within the ED. And the one area that went down substantially was the presence of the pediatric emergency care coordinators, because almost all clinicians were redeployed to care for adults during COVID. The national assessment in the United States is occurring right now, so we're very hopeful to see some marked increases in scores and changes over time. So why does this matter? Well, it matters because multiple studies have now shown an association with reduction in mortality in highly ready hospitals, meaning those who are compliant with the national guidelines and make that commitment have a reduction in the number of children who die of critical illness or injury. This is a study by Stephanie Ames and colleagues published in Pediatrics, which demonstrates a 4-fold reduction in mortality for children with critical illness in high-ready hospitals. This is another study by Craig Newgard and colleagues, which demonstrate a 42% lower odds of death in children in high-ready versus low-ready hospitals. And you can see the numbers there, and I think it's very significant in terms of those children who end up suffering higher mortality in low-ready hospitals. What's fascinating about this is not only has this been now repeated multiple times, but studies have demonstrated that that mortality benefit lasts for at least a year beyond the index visit in the emergency department. And finally, I think it is important to understand that highly ready pediatric EDs show a marked reduction in disparities in terms of the association with mortality between various racial groups. Not sure why this is true, it's just knowing that being highly pediatric ready reduces disparities in care. Here's another study by Newgard and colleagues looking, and this was in JAMA Network Open, and looking at pediatric readiness for emergency department visits. And what they found was that there was a 60 to 76% lower odds of in-hospital death associated with care in highly ready hospitals. This is phenomenal in terms of looking at all cases of emergency care, both illness and injury. So overall, over 2,100 lives would be saved each year by making all EDs in the United States highly ready. So what is the cost? It turns out it's very cost effective. It's somewhere between $4 and $48 per patient, or about, it could be as much as $12 per child resident within a state. But the bottom line is it's inexpensive when you look at the cost of other public health initiatives such as immunization. This is as cost conscious as any of those. And when we look at cost effectiveness, we see that raising the readiness of EDs in the United States would be highly cost effective, and more so than many current health initiatives going on in the United States. When we looked per state and nationally of 842 EDs that are highly ready as compared to the other almost 4,000 who have less readiness, we see that of the 7,600 deaths, 2,143 or 28% are preventable just by developing universal, highly ready EDs in the United States. So this is really significant work. And because of this work, many of the professional societies have taken notice and have now included these as part of the criteria for the American College of Surgeons Trauma Center verification. So adult levels and pediatric leveled facilities, trauma facilities, need to participate in the pediatric readiness assessment. They get a score, they get their gap analysis, and they are asked to develop an action plan to reduce gaps to ensure that they're highly ready. And when we mean highly ready, of a score of 0 to 100, it's 88 or above, and probably even better, 90 or above. The American College of Emergency Physicians, as part of their emergency department accreditation program, have also included a criterion for pediatric readiness. So all levels of accredited EDs in the U.S. will have to participate in the pediatric readiness assessment at least every 3 years during the cycle of accreditation. And what they participate, again, get their gap and develop action plans. And then finally, pediatric readiness and completing the national assessment are also a part of many state pediatric recognition programs. Here's the latest policy statement. This was just released in February 2026. And essentially, the statement has a number of domains, and you can see them listed here. Probably the hugest or the most impactful drivers of pediatric readiness are the assignment of a nurse and a physician, pediatric emergency care coordinators, or PECs, as they are called. Also, engaging in quality improvement activities, which include the care of children, and staffing the ED with board-certified EM or PEM physicians in the ED make a significant difference in terms of readiness. I mentioned quality improvement. There are a number of national pediatric quality measures. One way to participate is joining the NPRQI, or the Pediatric Readiness Quality Initiative. And so it is important to develop indicators for children. You should track the number of cases, quality of care, and variance in care. And really, when in doubt, we say assign the role of a pediatric emergency care coordinator, physician, and a nurse to ensure that readiness is maintained, and it helps prevent the waning of readiness. We do know that as hospitals become more ready, their mortality goes down. If they become less ready, the mortality goes up. So another indication that readiness matters. In the US, we have considerable resources available, not only the national guidelines, but checklists and really a comprehensive toolkit. When a hospital in the US completes the assessment, I said they'll get a score. So this is an example of what a GAP report might look like. You get your score, you get your site's previous score, and also how the entire nation is scoring at that particular time. And again, we're in the middle of the assessment. So this was a great way to provide initial feedback to hospitals so that it could be actionable by them to improve their quality of care. Overall, everyone who's participating in this conference can ensure your pediatric readiness of your ED. I would download the guidelines, get the checklist. It's really easy. It's part of the national guidelines now, a checklist, or you can go to just put in Google or any other search engine, pediatric readiness, and you'll get to our site. So let's talk about global initiatives, because I think this is critical and what's happening. There are a number of countries, almost 20 countries now, who have joined a global pediatric readiness network. And the idea of this, really its purpose, is to improve pediatric readiness in emergency care settings on a worldwide level. Part of the activities will be coordination of international efforts in not only advocacy, but education, research, scholarship, implementation of readiness, the evaluation of it, benchmarking against other areas of the world, and really the creation ultimately of global standards for pediatric readiness. We have some of that work ongoing, and I think it's important to understand that many countries have taken this on, and they're working towards improvement in pediatric readiness and outcomes for children. So the GPRN, or Global Pediatric Readiness Network, will work with international societies to really develop an infrastructure to lead efforts and coordinate efforts on a worldwide level. We would like to implement an analysis of current pediatric readiness standards and assessment tools, and you'll see some of that work. And then establish global standards for low resource, medium resource, and high resourced areas, really based on a international consensus. Finally, we'd like to develop a global assessment, very similar to what we have done in the United States, since that has been so impactful. And then ultimately, we'd love to study on a global level if indeed being pediatric ready based on these international standards improves outcome for children. So there's been a number of efforts on a worldwide level, and Canada, Europe, Latvia, you see Hungary, Denmark has done it, India is ongoing, Turkey is just starting, Africa, different areas of Africa and South America have also initiated some efforts within their country or regions to improve pediatric readiness. The International Federation of Emergency Medicine has developed pediatric standards of care. They have their version 3.0 has been published and is out there. The 4.0 is coming, and that is being revised even as we speak. So the bottom line is pediatric readiness of EDs is cost-effective and associated with reduced disparities and improved outcomes for children. PECs, or the Pediatric Emergency Care Coordinators, anyone who's listening to this lecture in their ED can assign that role to ensure that they have not only quality improvement initiatives, but policies and procedures in place that are compliant with national consensus, at least in the US, and some internationally with the standards from IFEM. Global Pediatric Readiness Initiative is building momentum on a worldwide level, and we're seeing more and more interest. And really, everyone here, you can empower your emergency care system to be pediatric ready. And really, I think we're all advocates for change and improving the lives of children. And with that, I say thank you, and I wish next time that we were live, so hopefully that will happen very, very soon. Thanks.
Thanks a lot, Dr. Mariana, for the nice lectures. I would like now, it's my pleasure now to introduce Dr. Mohammed Awain. MashaAllah, Dr. Mohammed is a chairman and a consultant in the medical genetic at King Faisal Specialist Hospital and Research Center, Riyadh. Dr. Awain will present an important topic about the metabolic disorders in children. Welcome, Dr. Mohammed. Bismillah.
Thank you very much. I would like to thank the organizing committee, Dr. Mohammed Al-Fayfi, and all the team for the invitation. Today I will be talking about the emergency care for common metabolic disorders. As you know, metabolic disorders can be challenging management-wise, and I will try to make it as simple as possible. There are too many metabolic disorders that are caused by specific enzyme deficiency or transport protein defect. More than 500 we know. And all of them, the pathogenesis stem from either excessive accumulation of substances normally present in small amounts, or deficiency of critical intermediates or end products in the metabolic pathway. As you can see, here is the substrate and here is the product. If the enzyme is working, everything is fine. Once you have a deficient enzyme, automatically there will be substrate accumulation, which can be toxic, or you can have deficiency of a critical product. We classify inborn nerve metabolism into organic acidemia. This is a very important group. Amino acidopathies, which involve amino acids, urea cycle defect, also another important group. And then disorders of carbohydrate storage, glycogen storage, lysosomal storage, fatty acid oxidation defect, gluconeogenesis, mitochondrial, and so on. The most important presentation that we will discuss today is the acute. You can have acute presentation with hypoglycemia, hyperammonemia, and metabolic acidosis. These three actually are the most important for the emergency room staff. It can come as a neurodegenerative picture with seizures, brain malformations, hypotonia, and so on, or it can be muscular with cardiomyopathy, skeletal myopathy, and so on, or it can be slowly progressive storage-like with hepatosplenomegaly. It could be also involving the CNS, the bone, and so on. Now let's go first to the common disorder and common presentation. Not unusual in the emergency room, you face a child who is encephalopathic, and the differential diagnosis for encephalopathy is very wide. including inborn error of metabolism. It can be caused by urea cycle, by organic acidemia, by maple syrup urine disease, which is an amino acid metabolism defect. Now, continuation for the presentation. The typical symptoms with encephalopathy include lethargy, poor feeding, apnea, tachypnea, recurrent vomiting, and it can be associated with metabolic acidosis and or hyperammonemia. This is a child who presented with encephalopathy, comatose. This is due to organic acidemia, particularly propionic acidemia. And if you look at the brain MRI, it shows basal ganglia infarction and metabolic stroke, which is seen in this type of diseases. Another child undergoing peritoneal dialysis who is encephalopathic because of very high ammonia level. And hypoglycemia can be caused by several disorders or several group of disorders, including glycogen storage diseases, gluconeogenesis, fatty acid oxidation defect. I think hypoglycemia is easily recognizable because any child who is sick will have immediately a glucose check done, and that can be easily recognizable. And also easy to manage because I think you guys are really good with this. Sometimes patients can present with hepatic presentation, with jaundice. And it's an acute presentation because they can be really sick and they need relatively urgent intervention. The group that cause this are galactosemia, hereditary tyrosinemia, and sometimes neonatal hemochromatosis, although uncommon. There are too many liver diseases, but they are outside the scope of metabolic diseases. The two main treatable conditions that come to our mind are galactosemia and tyrosinemia. This is a child who's severely jaundiced, having severe ascites, and his liver function showing fulminant hepatic failure, very critical with tyrosinemia. A treatment called NTBC can reverse all these symptoms. How do we make the diagnosis? We'll try to make it very simple. There are two main levels of diagnosis. One is biochemical, and we mean by biochemical all blood tests that measure all metabolites or basic workup, and sometimes enzyme assays, or molecular, which is the DNA. And honestly, the DNA analysis or the molecular diagnosis has dramatically changed the diagnosis or the diagnostic dilemma for many patients. The main problem with the molecular diagnosis, it takes time. So if you look here, this is the DNA. It gets transcribed to RNA and then protein and then the substrate and product. The DNA, if you sequence the DNA here, then this is the molecular diagnosis or DNA analysis. We normally don't do RNA at the bedside. It's usually done on a research basis. So this part I will skip. Enzymatic assay or protein analysis usually left for the clinic, in the metabolic clinic, and usually it is relatively cumbersome, not an easy test to do. And you can measure other things like the substrates and the products by the either routine tests like ammonia, metabolic acidosis. You can measure amino acid analysis. You can do the metabolic screen, urine organic acid analysis by this machine, or plasma and urine amino acid analysis by this machine. or using tandem metabolic screen, another machine that is used to measure different metabolites to reach the metabolic diagnosis. There is a battery of tests that we normally do, including the blood gas, glucose, urinary ketones, plasma ammonia, renal function, liver function, uric acid, CK, lactate and pyruvate, blood carnitine level, ketones, we can specify them like beta-hydroxybutyric acid. And also we do, as I said, the urine organic acid and amino acid analysis. Newborn screening has actually opened doors for early diagnosis. Many patients are diagnosed with PKU, with several metabolic diseases early on before even symptoms start. Occasionally, a baby is discharged from the nursery and then all of a sudden present on the 3rd, 5th day with severe metabolic acidosis or high ammonia. And when we go back to the metabolic screening, we may find the clue to the diagnosis. Now, how we acutely manage these cases? There are basic principles that I would like you to understand. Number one, these patients, they require fluid. So they need a normal saline bolus at the beginning. Number two, they need high glucose infusion to stop catabolism. Because of the stress that they are going into, their own proteins in the muscles is getting broken, and as a result, they go into catabolic state, which aggravate the metabolic problem. So one way to do this is to give them high glucose with vigorous hydration, and this is very critical. And that's why we use more than at least dextrose 10%, and sometimes more, depending on the line that you have, at least 1.5 maintenance. This is basic, intervention, especially in the first 24 hours. The first 24 hours, we keep the patient in PO. And then depending on, are we dealing with organic acidemia, for example, or are we dealing with urea cycle, we will go through this. So if we have high ammonia, for example, we have to think about scavengers like sodium benzoate, phenyl butyrate, and so on. If we are dealing with urea cycle, then we give arginine. IV arginine is a must. For organic acid ureas, we give IV carnitine, and for metabolic acidosis, we always give sodium bicarb infusion. So long-term management, of course, here we will intervene in the clinic with a special diet, with oral medication. I don't think it's the place for the emergency room, but we tend to focus on this in terms of long-term therapy. We also use cofactors like vitamin B12, vitamin biotin, for example, and so on. Let's give you now specific disorders one by one. We were talking about group of disorder, how to manage in general. The most common disorders, I will say, are organic aciduria. Two main important ones in Saudi Arabia, methylmalonic and propionic acidemia. If you receive a patient from the south, then propionic acidemia is more common. From other parts of the country, from the west, the north, and so on, the methylmalonic is probably more common. If you are dealing with somebody, now organic aciduria, they present two main presentations. Severe metabolic acidosis, that's number one. It's a must in their presentation, and high ammonia sometimes. MSUD, they come encephalopathic with very high leucine, but normal, usually normal labs, no acidosis, no normal ammonia. Urea cycle, mainly high ammonia, and normally they don't have acidosis. They tend to be alkalotic, actually. And the common example are arginosuccinic, citrullinemia, OTC, and CPS. All of them, their management are very similar. There is one group called biotinidase. There is one disorder called biotinidase. It is treatable condition. They can come with seizures. That's why they can come in the emergency room. They come with skin rash. They can come also with optic atrophy, hearing loss, but mainly skin rash, hair loss, and seizures in particular. And they are easily treatable with high dose biotin. This is the biotin cycle. I will not go through it that much, but mainly the biotinidase is very important to release biotin from the proteins and other products, so it can be freely it can be free used by the enzymes in the body. This is a skin rash, severe skin rash, difficult to treat without biotin in children with biotinidase deficiency. Homocystinuria, I don't think it will be an acute presentation unless they come with a stroke. They can come with a stroke because they have thromboembolic phenomenon related to high homocysteine. We have to measure homocysteine in their blood to make the diagnosis. And if homocysteine is very high, it tends to be diagnostic. Remember, they have also lens subluxation, normally downward compared to Marfan, which is upward. They tend to have mental also deficiency, mental subnormality compared to Marfan. Marfan, usually they have normal intellect. GSD type 1 is the most common cause of glycogen storage disease. They tend to have severe hypoglycemia, usually before feeding, significant hepatomegaly, and they require NG feeding and a special diet by our dietitian, and they can come to the emergency room as well. Pompe disease, they can come with severe hypotonia, cardiomyopathy, high CK, and they require enzyme replacement therapy. That's another disease. Now let's speak about hyperammonemia. This is a must. You guys have to know this in the emergency room. First of all, as I told you, that we have to give high dextrose with the high hydration with dextrose 10% to prevent catabolism. We have to rapidly clear ammonia with ammonia scavengers like sodium phenyl butyrate, sodium benzoate. And if ammonia is very high, we use sometimes dialysis, either peritoneal dialysis or hemodialysis. If we are dealing with urea cycle, we use arginine. And if we are dealing with organic acidemia, carglumic acid, or also called carbaglu, can be also used to treat hyperammonemia in these cases. We tend to give them emergency letter once they are diagnosed to help the emergency physician how to recognize the disease and how to treat. So they need supportive therapy with IV fluid, high dextrose, keep MPO for the first 24 hours. Sometimes they require intubation and ventilation. We have to, as I said, stop protein intake in the first 24 hours. Dextrose 10%. If ammonia more than 200, give arginine, benzoate, phenyl butyrate. Give carbaglu for organic acidemia. If more than 400, start dialysis, prepare for dialysis. Now, let me give you some examples, because I think there are 3 examples I will give you here for the next 10 minutes or so. They are really good examples, and we'll walk you through how to make diagnosis and management. You are evaluating a neonate in the 3rd day. who started poor feeding and then went into coma, dehydrated, hypothermic, hypotonic, with appendicular hypertonia. His white blood cell on the low side, 3.8, hemoglobin 11.6, platelets on the low side, 58. Sodium 135, chloride 101, CO2 7, this is bicarb. Glucose very low, 1.1. pH, acidotic 7.1, and bicarb 8.1. Ammonia 278, and ketones 3+. So the first question, what's the primary metabolic problem? Look, if you look here, there is severe metabolic acidosis. And bicarb is very low. And ammonia is also high. So there is a combination of two. This is typical of organic aciduria. And in Saudi Arabia, you are dealing most likely MMA, methylmalonic, or propionic. As I said, if you are dealing with a family from the south, you are dealing with propionic, and otherwise MMA is more common. They tend to be ketotic, and they may have hypoglycemia, they may have hyperglycemia, and they may have also normal glucose. Now, the second question, what is there acidosis? Yes. And what's the anion gap? Many times you guys forget to do the anion gap. Here, 135 minus 101 minus 7. Here, it would be probably 27 or so. So it is typical high or elevated anion gap. Because if you deal with a normal anion gap with metabolic acidosis, you are dealing with either renal loss or chloride loss. And there is one disease that is very common in Saudi Arabia. It's called osteopetrosis with renal tubular acidosis. It can cause, they can present with bicarb of 12, but normal anion gap. And in that case, if you do bone X-ray, you will find the osteopetrosis. So the metabolic diagnosis, as I told you, it's an organic acidemia. Now, here we will do immediately tandem metabolic screen. We will do plasma amino acid, and here we will find something called C3 carnitine will be very high. And we will find 3-hydroxypropionic high if we are dealing with propionic acidemia, or methylmalonic acid high if we are dealing with methylmalonic acidemia. How we treat? Immediately we will give a bolus of normal saline, start D10 with appropriate electrolytes, and at least 1.5 to 2 or double maintenance, give sodium bicarb. You can give 1 to 2 milliequivalent or millimole per kg, and you can repeat until at least you push the bicarb toward 14, 16, and you add 40 to 80 millimole per liter in the IV fluid, depending whether you have a central line or no. Normally, this patient will go, of course, to the ICU. For the ammonia, usually ammonia, here in this case, ammonia will respond to the hydration. We will give IV carnitine here, by the way, because we are dealing with organic acidemia. We will give 50 milligram per kg per dose every 8 hours, total 150 per kg per day. And we can give carbaglu because we are dealing with organic acidemia. Carbaglu, it will strengthen the urea cycle because it is suppressed in organic acidemia. And you normally, with this intervention, ammonia will come down. We normally don't require dialysis here. If you have, rarely, you may have refractory metabolic acidosis. That can be an indication for dialysis. They usually respond to management immediately. So this is the first case. The second case, 3-day-old, quickly profound hypotonia, coma, and cardiorespiratory collapse, intubated in the emergency room. Here, white blood cell is okay, hemoglobin is fine, sodium chloride, CO2, and NGAB is fine, glucose is okay, slightly alkalotic, ammonia is very high, more than 1,000. So this is typical of urea cycle. And urea cycle, there are two kinds. There is early defect and late defect. Early defect, they tend to have early presentation like the third day of life, and they tend to have very severe hyperammonemia like this, more than 1,000. Here we can be dealing with OTC because this is a boy, or it could be also CPS, which is boy is the OTC is an X-linked, and CPS is autosomal recessive. Here, the management will be dialysis, of course, immediately, and they will require also scavengers with arginine, IV aminol, the sodium phenyl butyrate and sodium phenyl acetate. And many times they will go into cerebral edema. Sometimes some of these children are very hard to treat, and they may die because of the severe hyperammonemia. They may require liver transplant because even if we treat them, they will come back again with severe hyperammonemia. For the late defect, which is arginosuccinic and citrullinemia, they usually respond nicely to arginine. Normally, the ammonia is less than 1,000, but they normally respond high to arginine, and they may require also the scavengers with sodium phenyl butyrate and phenyl acetate, and they require also high dextrose with high IV fluid, the same. They don't require bicar, they don't require carnitine. So we told you what is the primary metabolic problem here. We told you the anion gap is normal. We saw the ammonia very highly elevated. We said it's a urea cycle, most likely early defect. And the abnormal lab here, you saw the ammonia, and we spoke about the active management of the disease. The last case is a mother lost 2 infants with metabolic disease, delivered baby 5 days ago, and then came to the emergency room with abnormal movement lethargy, opistotonic positioning, boxing, pedaling movement, looks like seizure, abnormal odor, and in the urine, and all labs are normal. Basic labs, CBC, electrolyte, glucose, blood gas. So here, this is a typical presentation of maple syrup urine disease. And here, the urine will smell like maple urine, maple syrup, and اللي هو السكر المحروق. And this one needs really a high index of suspicion. Here, you have to stop the all protein intake, give high dextrose, probably 20-25%. You may use insulin. Check plasma amino acid. Of course, you will involve the metabolic physician. And, you most likely dialysis may be required if leucine is more than 1,000. Especially if they are severe, they have severe CNS insult, then most likely they will require dialysis. They will require a CT brain. All these cases will require CT brain to assess cerebral edema or stroke, metabolic stroke. So the primary metabolic problem here is basically leucine encephalopathy. Leucine, you have to measure plasma amino acid, not readily available in all emergency room. And the suspected metabolic disease is MSUD, and the lab test plasma amino acid. Here we have to call the lab and expedite the test. And the treatment again is the same, high dextrose, but here in MSUD we tend to use 20%, 25% dextrose, even with insulin, to promote anabolism and stop catabolism. And often we have both the low threshold for dialysis. Once you do this, normally the leucine will come down and the patient will be better. All these diseases that we mentioned, MSUD, arginosuccinic, citrullinemia, urea cycle, propionic, they are amenable to liver transplant. So early diagnosis is critical, early management is critical. MMA is debatable, but some cases have been taken to liver transplant. We need to build more experience with them. But the majority of these conditions, they require will have significant improvement after liver transplantation. 2 points, if you are thinking about biotinidase, then biotin is the treatment of choice. And for suspected cases of tyrosinemia, there is a treatment with NTBC or nitisinone, which shows a dramatic also improvement. With this, now exactly, I think 30 minutes. So thank you very much all for listening. And I will be more than happy to answer your questions or receive your comments. Thank you very much.
Thanks a lot, Dr. Mohammed, for this and important lectures. Jazakallah khair. We will go now to the break. I will come back at 10:50 a.m. Inshallah. We have, please make sure that you fill the evaluations. We have 2 forms. The one, you will find it down in the polls and quizzes. You need to fill that evaluations. This for Saudi Council hours. And also, of anyone who want to get also a certificate from ASIP, American, for the certificate of this conference. You have already attached to the chat here an evaluation form. Make sure that you fill it all. So better to do both. So you can get both certificate from ASIP and from Saudi Council. For Saudi, you have it in the polls and quizzes down, and or whatever the application that you are using. Please find the polls and quiz and fill the evaluation there. And the other one is ASIP evaluations. So thanks a lot, and we will have break, and we will meet again, inshallah, at 10:50 a.m.
Hi, my name is Dr. Marian Gaushi Hill, and I'll be talking to you on navigating pediatric non-traumatic surgical emergencies. First of all, I have nothing to disclose relative to this lecture. And we're going to be covering a number of non-traumatic abdominal surgical emergencies in pediatric patients. I'm going to do it by presentation of cases because I think that's most illustrative. And then we'll talk about diagnosis, how do you make the diagnosis, and what are the management priorities. So let's begin with case 1, and this is case of the bloody stool baby. And this is an actual case that I actually pulled off the internet, and there's the reference to it. This is a 7-day-old female born at 35 weeks via emergent C-section and presents 7 days in, so a week after, with bloody stool and lethargy. So when we think about differential for bloody stools, it can be a lot of things. The most common that we see are anal fissures, although with associated lethargy, we really have to think of things more serious, such as malrotation and necrotizing enterocolitis would be the things that I would be thinking about early on. But it can range from infectious, milk soy intolerance, which is nothing, intussusception, is also very common, but this baby is very young, and within the first couple of weeks of life, I think I would be thinking necrotizing enterocolitis or malrotation as my top possibilities. So this is a case of necrotizing enterocolitis, and the bacteria invade the intestinal wall, and they get between the layers and cause air gas accumulation, which can lead to microperforations all along the way. And it can occur in about 10% of cases in term infants, but the majority of them are very young, as in this case, which are less than 2 weeks of age. And you often see it within days of delivery. There may be some stress relative to this, but it's important to understand. So the image on the left, it basically shows air. This is air in the biliary tree, which is certainly very concerning. And again, air tracking all along the wall of the intestines. And so the presentation can be similar to our patient, which is bloody stool and lethargy. But it can be quite serious. Poor feeding, vomiting is really common. That's what I've seen early on, is an inability to feed, abdominal distension they get, and they can be somewhat tympanic, and then abdominal erythema in severe cases. In imaging, getting an X-ray can be really helpful to see air in the bowel wall, as demonstrated here. And AI has been used and been shown as accurate as MDs in order to pick this up. Some of it can be really subtle. If the X-ray is normal, it can't rule it out, but typically you would see some findings of air in the bowel wall early on. It could be considered normal. And then again, ultrasound can be useful to look for a kind of a whirlpool sign, especially with color Doppler for malrotation, but it's less useful in this case. So we'd get abdominal X-rays, you'd get your normal labs that you would, including blood cultures. You'd put the bowel at rest with a nasogastric tube. I would consider getting a rapid glucose, especially with the lethargy. And again, if a low glucose, you might add dextrose. And these patients need to go to the NICU, and depending on the rules and where you practice, some of these patients actually go to the PICU and not to the NICU. But one way or the other, they'll need broad spectrum antibiotics and co-management with your surgical colleagues. When do you have surgical management? Signs of frank peritonitis. So they often have abdominal distension, but it's really peritonitis, rigidity, metabolic acidosis, elevated lactate, or portal venous gas would be an indication as well. So what happened here? This baby underwent fluid resuscitation. A radiograph showed the pneumatosis intestinalis. They started on broad spectrum antibiotics and bowel coverage, Amgen and Flagyl or metronidazole, surgical consultation, and again, bowel rest. Overall, was started on TPN, and then gradual feedings occurred, and the child did well ultimately. So this is necrotizing enterocolitis. Again, typically presents in the first 2 weeks of life. So this is a picture from the APLS course. This is a baby that came in with a 2-week-old with female with bilious emesis and lethargy. Now I find I'll be honest with you, in the cases that I've seen, a number of these kids, it's so striking when they have the bilious emesis, but the green emesis, that parents bring them in. And generally, I've seen it fairly quickly. So some of these kids look relatively normal or slightly dehydrated, but they can be lethargic, as in this case. So this baby looked really sick, abnormal appearance, abnormal breathing, as you can see, tachypnic, abnormal circulation. So this is a child that needs resuscitation, supplemental oxygen, IV access, fluid resuscitation, and it's, if indeed with the bilious vomiting, I would initiate surgical consultation almost immediately, just because it takes time sometimes to get the pediatric surgeon in. This child had a general impression using the pediatric assessment triangle with really all of the arms abnormal, of either shock or cardiopulmonary failure. And sometimes you'll see grunting that will be due to hypoxia or to intra-abdominal catastrophes. So we began cardiorespiratory monitoring, obtaining IV access, started 20 mils per kilo, perform rapid glucose. We would do supplemental oxygen for sure. And the decision is when you secure the airway, I like to put them on supplemental oxygen and fluid resuscitate them first before securing the airway. And again, I would get imaging. There's a couple things you could do: color Doppler, ultrasonography. You could do a CT, but again, we're going to touch upon imaging, and really ultrasound could be used in this case. When we see undifferentiated sick kids, so a kid that doesn't have, say, a history of congenital heart disease, and they come in and they're really ill, you need to think of some of these things, such as intestinal catastrophes. Now, this happens to be a discussion on non-traumatic surgical abdominal emergencies, so we're going to think of intestinal catastrophes, but I want to make sure that you keep the differential pretty broad. The misfits is a mnemonic that can be used. So trauma, heart disease or hypoxia, endocrine, like congenital adrenal hyperplasia, thyrotoxicosis, or things like insulin, diabetic emergencies under endocrine, metabolic, electrolytes and glucose, hypoglycemia, hyponatremia. Inborn errors must be considered in all of these cases. Although newborns are screened with hundreds of potential genetic disorders, it may be only the time of stress that it's manifested. So they have a low level of enzymes, so the test does not indicate that they have a disorder when actually they do. And once the infant is stressed, then you see the inborn error manifest itself. Sepsis, formula mishaps, such as too much dilution. The intestinal catastrophe we're talking about now, toxins and seizures. So this is something any infant with green vomitus, you have to think about malrotation, and about 30% present by 1 month of age. Generally, I've seen the large majority under 5 years of age, but they can present at any age. And as mentioned here, and has been my experience, 50% have a normal abdominal exam at the time of presentation. So this is how they present. Most of the time it's with bilious vomitus, sometimes lethargy, Could be chronic or intermittent vomiting and abdominal pain that we see as it twists a bit and untwists. And then it's, you can see distension, and you can, like in this baby, and presence of shock. The upper GI is seen in the upper radiograph. It was considered the gold standard. Now ultrasound is very sensitive and specific, and it's really considered potentially the best option, more readily available. You typically need to call somebody in for the upper GI. Abdominal x-ray is rarely useful, and CT if you don't have any other means. And again, you may see both on CT and ultrasound a whirlpool sign as the bowel is twisting around the superior mesenteric artery. So workup, standard labs, I do blood cultures. You would initiate fluid resuscitation, and again, might consider fluid with dextrose, since this is a metabolic challenge to the child. NG2 for decompression, antibiotics, and like I said, what I do is I call the surgeon immediately and said, I'm very concerned, I'm getting imaging, but I think you need to come in, and get them alerted from the beginning. So in this case, fluid resuscitation was begun, NG tube was placed, ultrasound showed the whirlpool sign. This patient was taken to the OR where necrotic bowel was removed, sometimes a large amount. In this case, it wasn't so, and that patient did pretty well 3 weeks post-operatively. So let's now go to case 3. This is the hungry vomiter. 4-week-old male presents with persistent non-bilious emesis and poor weight gain. This is a pretty classic sign. They're very hungry. When you start to feed them, you may see a peristaltic wave, and this is what you see. These photos are courtesy of Dr. Stan Inglis, who had a great photo collection, and a peristaltic wave that goes across and then reaches the level of obstruction at the pylorus. And you can also see severe dehydration. This is actually on the right, is tenting with severe dehydration. Should be dehydration here. So the baby would be placed on a cardiorespiratory monitor. Heart rate, as you see, was 190, respiratory rate 40, afebrile. You would initiate fluid resuscitation with normal saline and consider multiple boluses. I would get standard labs and preoperative labs. And then the fingerstick glucose in this case was 25, so you would initiate D10 at 5 mils per kilo, or at least 2.5 mils and recheck per kilo, and then recheck. So the differential for non-bilious emesis still includes, and I think this is really important, the most common is going to be gastroenteritis or UTI, frankly. The balance of these are less common. Malrotation can present with non-bilious. Ultimately, it will be bilious. And again, pyloric stenosis typically will present with non-bilious vomitus. So this is an example. These kids typically present between 2 and 6 weeks of age. Unlike what we see with neck under 2 weeks of age, malrotation could be really any age, but many in the first month and most by age 5. Pyloric stenosis presents typically 2 to 6 weeks of age, and the hallmark is progressive non-bilious vomiting, and that's why asking about the presence of bile in the vomitus and blood is important. So non-bilious emesis, and typically it gets more forceful. And they're very hungry, and it occurs generally post-emesis. The peristaltic wave you saw and palpable olive, they say it's at least 50%. I think that's by surgeons under anesthesia. I haven't typically felt the olive. The classic abnormalities are the hypochloremic, hypokalemic, metabolic alkalosis, although with severe dehydration, they could have a combined or mixed metabolic disorder or frank metabolic acidosis. Ultrasound is awesome. It's very sensitive and specific, and it can be performed bedside by trained emergency physicians. And workup, I don't always get a bunch of labs if they're not dehydrated. You may not need it, although some ORs require a set of electrolytes, a CBC, and a type-in screen. Ultrasound is key, upper GI if there's concern like for Malro, but most of the time ultrasound now is so good. Fluid resuscitation, you want to monitor glucose and then consult surgery. So in this case, electrolytes revealed hypochloremic, hypokalemic, metabolic alkalosis, and fluid resuscitation was begun. These are kids that don't need immediate surgery. You really do want to fluid resuscitate them, and so this child was taken after several days of fluid resuscitation and ultimately was discharged. Often these kids are operated on and discharged very, very quickly. All right, our last case, this is the listless child. So a 15-month-old male presents with intermittent severe abdominal pain and lethargy. This is a very common complaint for this. When we think about lethargy or the altered child, this is another mnemonic. I happen to like this one because it really keeps your differential broad. It's AEIOU TIPS. So alcohol, atypical migraine, child abuse, E, epilepsy, electrolytes, I, intussusception. So very worried about that with this kid. Overdose and hypoxia, uremia, trauma, insulin or inborn error for the eye, psychiatric or poisoning, and sepsis and seizure. And again, this is something to really consider for the altered child. So this is a typical case of intussusception, and I've seen so many different presentations of intussusception between just persistent vomiting with some lethargy, profound lethargy without a lot of vomiting. So you'll see it. And this is where the proximal portion of the bowel telescopes into the distal bowel. And the idiopathic version of this, ileocolic, is the most common. And it generally is supposed to be the most common cause of bowel obstruction under the age of 2. But I've seen it definitely older than 2. So it is something to consider at any age, but typically it's younger infants. And they often present with abdominal pain, really like screaming abdominal pain, and then lethargy. So intermittent abdominal pain, some describe that the kid pulls their knees to their chest, the infant, and I've seen that as well. You may see a mass, the intussusceptus in the right upper or lower quadrants, and then gross blood can be seen on rectal exam, occult blood, in about 3/4 of the cases. Imaging, ultrasound is the modality of choice. It's very sensitive and specific overall. You may see abnormalities in abdominal x-ray, although it's often non-diagnostic. And then air contrast, enemas are probably the modality of choice for therapeutics, diagnostic and therapeutics, but you would get screening ultrasound first. Generally, we ask radiology and some for consultation for the enema if the ultrasound is positive, and in others, surgeries involved as well. We only get surgery involved again if there is if perforation is suspected. Oftentimes, pediatric surgery is consulted at the same time, and they just monitor and ensure that things do well and the patient can be discharged. So that's typically what's done. Air contrast versus liquid contrast. Barium enema can be really great, but it's a higher radiation exposure, slightly lower success rate than air or liquid, like a saline. Higher complication rate, obviously, if perforation occurs. So most do either air contrast or just liquid contrast. And then reduction is successful most of the time. Perforation rates are low, which is good. So some of these kids are basically brought in for the enema. They're observed for a while and then discharged home. And with good return precautions, because about 10% can occur, and those usually occur within the first few days. So you want to tell parents if the symptoms return to please return. And in this case, after fluid resuscitation, the patient underwent an air contrast enema. Intussusception was found and reduced, although we knew that from the ultrasound. And generally, the lethargy disappears pretty quickly, and the toddler was discharged the next day. So in summary, early on, necrotizing enterocolitis can present with poor feeding, with bloody stool. We do see it for babies that had stress during delivery. So so something to ask about. Was it really a complicated delivery? You can see higher incidence of necrotizing enterocolitis. Malrotation, usually under 3 months, but the large majority will be under 5. And bilious emesis is the hallmark. Pyloric stenosis, very specific time period between 2 and 6 weeks. And for the pyloric stenosis to develop, and they present with non-bilious vomitus because it's the obstruction is at the level of the pylorus. And then finally, intussusception, lethargy and vomiting are really very common, and heme-positive stool is very common. So something to consider in the lethargic patient. So with that, we'll see if there's any questions. And thank you so much for listening, and have a great conference.
Thanks a lot, Dr. Mariana, for nice lectures. I think this was very informative. So now we will go to the next topic. So please join me to welcome Dr. Hamid Al-Madi. He's a consultant of pediatric and pediatric emergency. He's actually one of the pioneers in Saudi Arabia for POCUS ultrasound. Dr. Hamid also is assistant professor at Al Faisal University. Dr. Al-Madi, he will present now a wound care in pediatric emergency. Welcome, Dr. Hamid.
Thank you to have me today, and I want to thank the organizing committee and scientific committee. My talk today about the wound management in the emergency department. as you know, this is very common presentation for that patient visit to the ER with the laceration and wound. It is very important to be more familiar how to manage this patient. So it's very important to I didn't have any financial disclosure or any conflict of interest in my presented material in this presentation. There is 7 million presented to the emergency department in the US, around one every 4.5 seconds. So this is very common. So it is very important to be more familiar how to manage this patient who is present to the ER. Most of the cases, the laceration is in the upper limb, around 35, and the face is the second most common organ or part of the body, around 28, and the trunk is around 4.5, and lower limbs is around 12.5. The head and the neck is around 10% of that laceration wound in present in the ER. One of the important thing is that medical legal pitfalls that sometimes patient missed there is foreign body in the upper limb around 38, missed in the initial physical examination, maybe it's not appear, and unrecognized joint capsules injuries and violation, and there is maybe sometimes that's failure to detect that any nerve or the tendon injuries and wound infection can happen for that patient. The type of the mechanism of the injury is different from one laceration to the other. If the patient presents with the shearing force to the skin that can cause that sharp laceration, that will cause minimal change and injury to the subcutaneous tissue. The other type of the force can be that's compression or blunt trauma that can make more severe damage to the and be more deep than the the shared force. This can make that satellites shape of this that injury. Other type of force that's tension. That's blunt trauma can be moderate, also can make more deep little bit damage to the subcutaneous tissue. Can cause some triangular flap in the presentation of patient to the ER. The mechanism, face of that wound presented first in the first 3 days. This is hemostasis, inflammation, and this is platelet aggregated and coagulation cascade activation. That's macrophages that enter to clear that debris part of the tissue. And proliferative that's faced this from the 4th day to the 21 first day will be fibroblastic and endothelial cells will be synthesized as collagen, a new capillary form. The last phase, that's one remodeling, and that's one can make deposit collagen to be established to be permanent tensile strength and increase the strength of that collagen. If the patient presents to the emergency department, you have to take good history. How is that mechanism of the injury? Time since injury. Past medical history is very important. The patient is any comorbid disease or there is any problem like hemophilia, maybe is diabetic or renal failure or malnutrition. Any history of allergy is very important. You have to go for physical examination for the location and size and depth and shape of the wound should be able to be examined at a sign of the contamination or any foreign body or infection. There is any neurovascular status, there is an injury for this one. You have to examine the deeper structure such as the muscle and bone. For this patient with the laceration, no need for any laboratory study. Maybe can go for imaging for this patient, maybe 38 of that foreign body is being missed in the initial physical examination for this one. So delay in the management and for removal of the foreign body and can cause complication of that infection and delay for wound healing and inflammation. So sometimes you can go for ultrasound useful for detecting of the radiolucent foreign body. May can go for MRI CT scan to help to be concerned about any neurovascular compromise. The closure of that wound, there is 3 important closure for that. Primary closure, this one, any patient present with the full thickness, no risk for the infection, low tension, minimal contamination can be present within the window, safe window of this first 12 hours. Can be closed immediately with the suture or staples or glue. The other type of closure, that's one secondary closure. That's one present with poor approximation, high contamination, delay for the presentation, or active infection. So leave that open for granulation tissue. The delayed primary closure, that's when he is present with high risk of the infection, but require structure closure. We can keep that one clean and observe for several days, then later on you can make closure for this patient. The important for the patient for any laceration, prioritizing for returning to normal function and avoiding of the infection and any cosmetic presentation or concern. There is old beliefs that think about that wound can be closed within 6 hours. After that, will be increase the chance of the infection. The last literature showing that from 8 to 12 hours window can give the chance to be closed later, no problem. And the other literature showing that can be delayed to the 24 hours. And there is no any change in the chance of the infection. Only that decision of that there is other multifactor. There's not the time, the location, and if this wound is contaminated, that's increased that chance of the infection comparing the difference of the laceration. Other think about that suture can be just using sterile gloves and iodine for irrigation, or you can. There is a last literature showing that patient with some study, meta-analysis study showing no difference in the using of the sterile or non-sterile gloves, and using the normal saline can be used for irrigation, similar and same efficacy of this iodine. Anesthesia, you can use the topical anesthesia or intradermal anesthesia or nerve block or posterior sedation, depend on the how the patient present. Topical anesthesia can give that efficacy of that injection anesthesia. That will be avoid the reduce the need for needle injection and can be provided equal or even better than pain control for compared to the injection of the anesthesia. More comfortable for that patient. And there is evidence study to show that when you mix that tetrakine and epinephrine or cocaine, that will be work when injected more better than as injected anesthesia. And there is other study showing found the solution of 4% of the lidocaine and 0.5 epinephrine with the 0.5% of tetrakine can cause work with the equally well with that patient comparing to the TAC. the most important disadvantage with this one, slow action for this one. We can use in the triage to decrease the time of staying of the patient or waiting time. Intradermal, this one, it is the injectable anesthesia will still that's mainstream of the emergency care because this is very fast and reliable and easy to be used, and especially when the time matter. Lidocaine and is the most common use for anesthesia in the US. Sometimes it can be used with the epinephrine to prolong the effect and reduce the systemic toxicity and help for hemostasis. This is the different type of lidocaine and bupivacaine and mepivacaine and ribavirin. There's one different type of that agent and different dose depend on that. So this is maximum dose if you use with the epinephrine or no without epinephrine. If you use with the epinephrine, it's 5 milligram, 7 milligram for lidocaine. And the duration around 30 to 90. It depends on the concentration when you use this one as 1% or 2%. Depend how you calculate and what the maximum dose for this one. Bupivacaine, this one is 2.5 milligram per kg, the maximum dose, and the maximum dose with the epinephrine 3 milligram. This one will stay more than that lidocaine is 200 minutes. Also, how to reduce the pain for that patient with the intradermal by injection with the wound, not in the intact skin, and you have to warm that's the anesthesia, buffering this one with lidocaine with the sodium bicarbonate to be increase that's pH and inject slowly to reduce the pain. This is the nerve flow can use for this one. You can use the dorsal to injection between in the website, the different syringe, or you can use a single one in the fuller in the middle way to avoid that tissue distortion for this one. This is standardized commercial for this is concentration of lidocaine with the epinephrine is not harmful for the digital book and we provide better of hemostasis and long duration for this one. Procedure sedation, one of that technique can be used in the ER. That patient needs more extensive repair who are unable to be, is not able to be cooperative with the closure of the wound. There is two types of the suture types for this one stage. It is absorbable composition of that synthetic polymers and collagen. This is tensile will be lost and degraded by the enzymes and losing the strength within the 60 days. And you can use in the dermal layers and intraoral mucous layer. For that's one of non-absorbable. This is composition of this monofilament like nylon or polypropylene, and that tensile strength is not lost and stay with the maintaining the strength more than 60 days, not like the absorbable one, and can be used in the epidermal enclosure of where the low tissue reactivity and high strength are required for that patient. The size is the matter of the because potential for the cosmetic injury and decrease the chance of that scar after or that's area of the stitch area for that to increase the size depend on that when you are doing the suture of the face or the hands. Suture, you have to be more familiar with the type of suture, like a simple interrupted suture, continuous running suture, running subcuticular suture, or mattress suture, or corner stitch. And also this will talk about how to make good correction for dog age. Simple for the simple stitch, it is very easy to be how to hold that needle. You have to divide into 2/3 and 1/3, and you have to hold between the proximal 1/3 and distal part of the 2/3. And you have to, when you bite the skin, you have to be 90 degree enter the angle and go deep to the dermis and go to the other side. And you have to keep good distance, equal distance when you exit this one to the other side. Then you have to keep that version for that edge of that wound. And then after that, you can make your 2 loops for this one and tie this one to approximate and make good version for this one. About continuous is good for rapid application and best for long linear laceration disrupted by tension and distribute the tension and evenly and provide very effective hemostasis for that patient. And it is good use for that patient with the continuous and easy to do in the large one. Horizontal mattress, this is you can same technique of the simple, but we are trying this one to spreading the tension across that wider area, or that's one suture can be used for that wound, that's poor circulation at the edge and with the laceration under high tension. For this one, you can just go to one side and go deeply and go to the exit for one side, and same distance with the parallel for this one. You go again, bite again, and go to the other side and go make your stitch with the same distance. In this one, make good chance to keep that any lesion with the high tension for this one. For that mattress, vertical mattress will be going in far and near. That one will be bite far from that edge and go deeply and the dermis and go and exit in the one side, the other side, the same distance, and again go closely to the edge of this one and again bite to make that effusion for that wound. That's one good to make good effusion, and that's good for that to keep that wound with the under the high tension. Subcuticular, this one is good for to avoid the skin suture mark and completely and minimize dead space. And at the end of the suturing, you can keep loop. That one will be can tight, and you can bury this one at the end of your suturing.
This video is a demonstration of placement of a corner stitch, more formally known as a half-buried horizontal mattress. This is for V or Y-shaped incisions, stellate incisions. The first step is to go percutaneously through one edge of the tissue. What I typically do is reserve the edges the most flap-like. The horizontal mattress is good for that one, like can happen now. Essentially, we're going to drive this. That one is good to minimize the vascular compromise at the corner tab. Just go one side and go buried for this one in the epidermis. Then go to the other side and make your loop for this. Here, what we're going to do is reload our needle driver, and we're going to go back. For this one, if you're feeling there is some fault at the end of that one, that can give that picture of dog ear. That one can to avoid that. That's what find that one, and the complication can happen for this one by using complete simple stitch for this one. And at the end, if you find that fault, you can cut this one from the base for this one and cut the fold skin. Then you make your stitch like simple to keep this one without edge of this one.
Other modality of that's using for approximated in the wound that's using tissue adhesive. This mechanism liquid. This is monomer polymerized on the contact with moisturizing. Last more 5 to 10 days with the bacteriostatics properties. And this can be low for tension and linear edge, highly preferred for facial laceration, and reduce that emergency time for reduce the emergency stay in the emergency and decrease the pain for that patient. Application can be held in the margin of that perfectly approximated during that application and removed by the using of petroleum jelly. Other modality of this one, hair apposition. That's one technique. This one can be mechanism that clean that wound, twisting, opposing that hair by strand 360 degrees. That's one, and you can put drop of tissue adhesive. This can be simple, non-contaminated scalp wound with no active bleeding. You can no follow-up needed for this one to remove it. You can remove at home. Stable is fast and easy to be applied, cost effective, and is good for many laceration. But there's a problem, least precise for closure of that method is not ideal for cosmetic area. Best used for simple, linear, non-facial laceration. Avoid use for the face and neck and hand and feet. Practical can be used that removal kit that's ready in case of that stable is misfired or poorly positioned. This adhesive tape can be used. This one adhesive tape is over the simple and painless and quick laceration repair method, indicated only for the simple wound under low tension with the superficial skin tear. You should be placed and perpendicular to the wound and leave between that every 2 millimeter to the other one. It's easy technique. Other one, treating wound with the zip stitch. This is very easy. Can be avoid that suturing and more easy and very quick, and can give that outcome same what you can be find in the stitch. There is a special circumstances for this one. Most laceration can be handled by the emergency, but you have to be consult if you have complex injury like joint, nerve, vessels, tendon, or foreign body, or amputation, blast, or high pressure wound. Any patient present with the eyelid or medial canter or lip or hand, some intraoral wound, you can consult the other subspecialty for this one. Facial laceration is range from simple cut wound to the very complex in the ear and eyelid and nose injury. Main concern of cosmetic outcome. Tissue adhesive can be in 32% can be done by that adhesive tissue, and also suture around just only 30%. Adhesive with the strips around 18.6. So no needle is very good beneficial to less pain and shorten of the emergency time in the ER. No removal visit. Best for any patient can be prone for the keloid. Suture size usually 5 to 6 for that epidermis. Just only oriented barrel to the skin tension line to the best cosmetic for this patient. Eyelid laceration, this 5 layer with the eyelid. like skin and subcutaneous tissue and oculi muscles and tarsal plate, conjunctiva. Simple repair by the emergency clinician can be used in 6O and 7O suture for superficial laceration. Avoid any adhesive tissue adhesive for that's near to the eyelid. Refer to the specialist if there is anatosis or any margin disruption, lid the margin disruption or lacrimal duct injury or conjunctiva or tarsal plate involvement. Red flag if there is wound within 8 millimeter of the medial canthal. It's possible that lacrimal duct injury. This is summarized in the facial laceration. This is very important to be more familiar for this one. Wound in the eyelid within the 8 millimeter of that medial canthal can be potential for lacrimal duct injury. Avoid tissue adhesive near this one. Disruption of the tarsal plate, you have to call the ophthalmologist. If there is intraoral, if it's more than centimeter, or there is trapping of, it can be increase the chance of the trapping of the food or create of disruptive flap. So that's when you have to be corrected. Small laceration do not require any correction. Cheek can be used tissue adhesive or sterile strip preferred for reducing the pain and scarring. Align with the tension line. For the precise of alignment of that femoral, if there is any cut in the lips, you have to make good correction of the alignment of the femoral border of that is important and very crucial, important approach for this one. And what you have to do, go first orbital and mental nerve local anesthesia. Then you can make a line for the lip border first. Then you can go inside from inside, make closure, then repair the muscle by absorbable. Then after that, you can close the skin after this one. This is type of the suture. It can be used depend on the injuries to the face, and very important to be more familiar with the tension line. When will be used the nylon or absorbable, non-absorbable is very important. Intraoral laceration is more intraoral laceration, as you mentioned, is require repair. Not always require repair, but always be need irrigation of his and inspection if there is any foreign body. Indication for repair if they're more than 2 centimeter of flap or interfering with the showing or the laceration is trap food. The tongue laceration if it's small and non-gapping wound, no need for correction for this one. Cheek laceration is that consider about parotid gland and facial nerve. And simple cheek laceration emergency clinician can be repaired. Through and through, you have to repair and layer, start from intraorally, then re-irrigate it and close the subcutaneous, then close the skin. Facial nerve, you have to be checked in the first and at the end of the procedure. Thank you. I'm ready for any question. Thank you very much. You can go. Thank you. You can go for break. We'll be back around 12:30, and for the second session afternoon. Thank you. Welcome back for the afternoon session. and we'll start our first lecture for the afternoon session will be, it's my pleasure to introduce Dr. Saleh Al-Shehri. He's a consultant of pediatric and pediatric emergency medicine and the head of the pediatric emergency department at King Faisal Specialist Hospital and Research Center in Riyadh. Welcome, Dr. Saleh. He will be present a very interesting topic, how to doing casting and splinting for any patient present with a fracture in your department. Welcome, Dr. Saleh.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلوات والتسليم. I'm going to start my session, the workshop of the CAST applications in the pediatric emergency. My name first, I'm Saleh Al-Shehri. I'm working as a pediatric emergency consultant in King Faisal Specialist Hospital. Just to let you know that most of the illustration and graph that I created by myself, so there is no copyright for that if you need to get it. I'm using many tools to create it, make it simple, and hopefully, inshallah, we'll make it easy to digest topics today. The workshop maps today will talk about a little bit about pediatric principle and assessment, and about upper limb workshop station, and lower limb workshop stations, and common pediatric ED scenarios and complication if the time allowed be there. Let me go to the next. We need first to choose the splint versus full cast in the pediatric emergency and recognize common upper and lower limb immobilizations and describe safe application, molding, and bivalving and discharge teaching, which is very important point at the end of our treatment. We will spot red flags that need urgent review or different plan. Why this topic is important in pediatric emergency? Because good immobilization reduce the pain and help prevent displacement of the fractures, and later on the child will be growing. So there is no any disability will affect the patient in the future. Poor cast can create pressures, burn, also swelling problems, and repeat visit. And children and the parents remember always how them how to safe and comfortable the process that we are going to do it. Why children here different? Different because we have flexible bones here. Kids' bones are softer and more flexible. We're talking about growth palate, unique growth area bone to the injury and can maybe stop the growth in one limb. Stability issues here because the child is always moving everywhere. Soft and support for that. What's the growth palate mindset? Point tenderness here. It's very important over the physis. Deserve the respect here. And even when films are equivocals are normal, we should be there is a tenderness point there to highly suspected there is hidden fracture there. Avoid oversimplified, just sprain. It's not always, if there is point of tenderness, most likely it's not sprain, even with normal X-ray. When in doubt, here and anyhow, لما نشك في أي حاجة, just go to immobilize safely and arrange for appropriate follow-up. Right. We're not to put the full cast here. There's some contraindication that we're not allowed to do in a cast for the patient, like open fracture, severe swelling, or skin compromise. That when we worry about within the next few hours having compartment syndrome, neurovascular concerns or suspected of compartment syndrome, need for urgent reduction, operative care, OB reductions, and need to be frequent repeated inspections. What about the cast that we have it, plaster of Paris? The aim of the plaster is to immobilize the part of the bone and prevent the worsening conditions. A plaster cast or fiber cast is rigid to immobilize the device that is molded to get the shape of the body and to prevent any further injury part. POP or plaster of Paris means the plaster of Paris, which is hemihydrate calcium sulfate. By adding water, it will be solidified and easily to be mold and shaping the limb. So what's the purpose? What's the job of the cast here? It's apply as a first treatment to immobilize the bone or joint, act as a splint to apply pressures on the bone and to correct further complication and to observe signs and symptoms after applications. The cast also we need to assess the patients before doing the cast and applying the immobilization for the bone injury. Here we need to confirm the mechanisms, pain points, deformity, and swelling patterns. We need to review the X-ray and decide whether reduction or orthopedic input is needed, either by us as an emergency, or we need further advanced management by the orthopedic. And we need to be carefully choose the device that match the injury phase, either to do slab or cast or brace. Neurovascular exam here important before and after, and document all the pulse before the cast and after the cast, and the perfusions, capillary fill, sensations, and movement. We need to frequently repeat the exam after the splint or cast is on. Escalate immediately if the pain or numbness or pallor or weakness worsening, and we may need to remove the cast. Right. About the skin swelling, rings, and wounds, inspect the whole limb, not only the painful point. There's maybe some practice that only we going to examine locally. No, we need to examine the whole limb. We need to remove remove the rings, bristles, and tight clothing before swelling increase, and bad bony points and protect fragile skin or wound itch. Very important in emergency here to pain control, control the anxiety, and need to have child-friendly environment and the communications. We need to use simple language, distractions, comfortable measures, and analgesia early. We may need to use procedure sedations here. So we need to insert the line and use appropriate sedation to treat the anxiety and the pain and make the procedures much successful here. Explain every step to the parents and the child before you touch the limb. And this will make the family much comfortable, that feeling happy that you are easily communicating with them. The indication of cast here, there's a bone fracture, as you know, dislocation, soft injury, ligament injury. Is not only the bone injury, I mean. Joint swelling due to the disease, nerve, tendon, fissures repair. And for Achilles and calcaneus tendons, if tears or ruptures inflamed, this is one of the indications for preventing movement, the limb, and to minimizing the pain. Material that we needed to be ready before the casting, we need to have a cotton padding and the cast material, scissors, stockinette and padding and slab or cast material bandages, scissor, water, gloves. Better not to have very cold water. So it will be accelerate the dryness. Choose the width that match the child with the limb. Have a towel, sling, and helper. We need, most important, second person to make sure about the alignment and you are comfortable to apply the wet material to the limb. The material that you want it ready before starting, as we mentioned it. Plaster of Paris, POP, versus the fiberglass. The advantage of POP is molds beautiful and is for fresh reduction and splint and dry very fast. Good working feel for teaching also because it's cheap and for more delicate counseling. Cooler water here will give more working time, so better to use a little bit warm water. The fiberglass here is lighter, stronger, beautiful colors, much cleaner. Once the lip is ready for that, but more difficult to mold it than compare it to the pup. Useful after swelling, settling, and more durable immobilizations, more comfortable for the patient also. Still need to be careful in petting and trimming the lines because also they having sharp line here that we need to be careful here. What's layer by layer? Building a staff cast, stuck in it, a smooth inner slab, protect the skin and create net edge. Then we'll apply the padding, cotton there, overlap, evenly protecting the bony prominence without thick, rigid. Then we'll apply the rigid layer, the plaster or fiberglass there. And the finals, we need to smoothing the edges there. Any bandage extra that we need it, like back slab, we can apply it after we applying the cast. 5 steps here in the emergency for workflow. Prepare, explain the plan, position the child, the size and the material, and assign roles before wetting anything. Be careful about what you're going before wet anything because the cast will dry fast. Protect, apply the stockinette, patting smoothly, especially over the bony prominence, and lay the wet material with the gentle overlap and no wrinkles because every wrinkles we may have bit sore behind it. Mold, use broad palm to counter the cast and maintaining the desired positions, and then recheck. After the cast, inspect the edge, expose the digits, elevate it, make sure about the neurovascular examinations for that. The positions here and the role of the assistants here. One person here will maintain the alignment, while one person wraps and molds. Position the joint exactly here where you want it before the hard layer sit. Support the limb with palms and pillows or stable surface. The most important that your helpers or assistant person need to know the next step. So the alignment of the limbs will be perfect. About the molding, how to do the mold, it's better to use the broad palm here. So you mold it smoothly there and avoid any wrinkles. To shape the cast, make sure about the fingertips create dents that become painful focal pressure points. So be careful about that. Support the reduction or desired alignment until the material hardening. Don't leave the patient, leave the hands or the limbs until you make sure all the materials or the cast getting hard. Trim lines, the trim lines here. So avoid the trim lines that block metacarpal joints around the edge here. So this extra, so to not be sharp, so to be easily make any injury for the patient. Safe edge improve the comfort and functioning and discharge success. There's something called the bivalving. And when to revisit the plan, bivalving or splint, this is used when swelling risk is high, or you may think about patient may develop compartment syndrome. So this is the 2 layers here will make the hand in stable and aligned positions, and you can open it anytime easily and inspect the limb. Turn tight circumferential device into safer monitoring device. Helpful when you expect the child will revisit your clinic or the emergency within the next 3 days. Reassess the plan here. Splint may be safer than the full cast that we need to sew it and open it and break it down and apply it again. Tell the family clearly that today's device may not be the final device and revisit the plan whenever the pain swelling or skin concerns change. Documentation here is very important. I like the documentations here, which is can save the patient and save also the physicians. And discharge plan, record the diagnosis, site and devices and the positions, and pre and post application neurovascular exam. Document everything, document the reduction if performed, and if you use analgesia or sedation there, and the child tolerance to the procedures. Give written cast care and written precaution. State clearly whether the child is weight bearing or non-weight bearing. Document who received the teaching, either the mother or the father or caregivers or the watcher there, or all. Common mistake here is better to avoid it is to make it too tight cast. Make sure that the finger or toes trap in. Too little padding over the coeloid, heel, malleol, and elbow or fibular head. Wrap too tight to make the cast look neat. Using fingertips to squeeze shape into soft material. Discharge before repeat neurovascular check, and this is one of the common fault in pediatric emergency. Upper limb here, we need to know about in this slide about the device that we need to apply it. We have the volar slip, which is stable wrist pain, buccal types injury, or quick emergency support the room for swelling. Another type is called sugar tongue, which is for distal radial ulnar injury when the rotation control matters. So this will avoid have some movement, comfort movement for the hand, but it will prevent any rotations control there to make the fracture stable. Posterior long arm, which is elbow injury and unstable forearm patterns need elbow control. Thumb spica, which is for scaphoid concerned fractures, thumb ligament injury, or any first metacarpal injury. Ulnar gutter here, which is fourth and fifth metacarpal or proximal phalanx injury. Type of cast. A long arm cast also, it's applied to the arm from the hand to about lower two-third arm, leaving fingers and thumb free. Indication for elbow and forearm injury, maybe for supracondylar type 1, but definitely not for type 3 and 4. Distal humerus also fracture, so we'll make heavy weight here, so allow the alignment of the humerus. Both bone forearm fractures, unstable proximal radius, or ulnar that need more force to control it and prevent any movement there. See the movement here, just simply how to apply the upper limb cast here.
Every time it comes down a bit, so try to make it all the way up to the shoulders. Once you got that, yeah.
So first apply the socknet here.
Nice protection.
So here we apply the cottons here, wrap it around.
The elbow. Now, before you put the cast, make sure your position is right. The cast always leave about 10 centimeters. Nice, you can put it in the water and then won't have any trouble getting it out.
So the average is 1 centimeter width for the average persons, but you can change it according to the limb size. Careful, don't squeeze the material, so not all the gypsum will be out.
to the forearm, protecting the soft structures that cross the outer side of the elbow and go back up. We protect this, and now we cover it. Make sure the cast rolls over itself. Do not lift it like that. Just make it roll. This is our first cast and back. Okay.
This is another layer applied to the cast.
Here, some people just do this. No cuts. Go around the wrist almost 2 or 3 times. This right here.
Right. Short arm cast here, cast below the elbow. The distal forearm fractures indications, carpal and wrist injuries, some metacarpal fractures, buccal fractures, and minimal displaced fractures of the distal radius. And if we need to immobilize the forearm after surgery. Volar slab that's good for many wrist injury and selected stable distal forearm problems and support the wrist while leaving the room for swelling, and common emergency choice when you want comfort, speed, and very easy, very simple, and many of us use it. So just to stabilize the fractures and send them to the clinic of the orthopedic.
Onto the arm up to the elbow crease. Punch line skin, plasters fly. With the short length of stock pad, orienting the split end toward the front space. Wrapping softball proximal to distal, starting approximately 2 finger widths distal to the elbow crease. Add 2 layers of softball approximately distally overlapping by about 50%. Tension the softball throat wrap to avoid bunching. Wrap in a crisscross fashion around the hand and wrist. Tails fasten to the first web space. 2 layers of softball on the hand, extending no further than the palmar crease to leave the metacarpal phalangeal joints free. Wet the first plasma, apply from proximal to distal, starting with 2 layers, proceeding distally, overlapping by approximately 1/3. Tension the plasma appropriately to keep snug. Wrap in a crisscross fashion around the hand and wrist. Tension the plasma while passing through the first web space. Fold for stockinette proximal at the base of the thumb and distal. Wet the second plasma and apply a similar manner as the first, ensuring that there is no contact between the cast and the skin. Hold the cast appropriately as dictated by the fraction pattern. While still wet, smooth the plaster to divide the finish. The finished cast should allow excellent movement of the metacarpal phalangeal joints, base of the thumb, and the elbow.
So another one's called arm cylinders, which is it's cover the upper and lower arm and the elbow, but will leave wrist and the hand free. The indication here for elbow dislocations here, that's contraindication for most acute fractures, fracture that need open reductions, injury with the neurovascular compromising, and fracture with the active swelling. Posterior long arm splint, which is common used in the emergency, useful for elbow injuries and unstable for arm fractures. Typically placed with the elbow at 90 degree. Watch the antecubital and olecranon areas for padding and edge comfort. finger and thumb spica here. It can be including long arm cast or short arm cast. Indication suspected of injury of scaphoid here, stable ligament injury to the thumbs. Initial treatment of non-angulated or non-displaced fractures. Immobilize the thumb appropriately while keeping the other finger stable. And allow all the finger to be moved, and even you can allow the child to using the hand, four fingers here. Explain the family why the X-ray may be here most of the time. X-ray it can be normal here, but thumb spica still need.
Soft roll growth around to avoid bunching. Wrap in a crisscross fashion around the thumb, hand, and wrist, tearing soft roll while passing through the first web space. Ensure that there are 2 layers of soft roll on the hand, extending over. Wrapped around the base for any excess like splinters. Joints in the elbow.
Excellent. So this is about sugar tongue splint. Sugar tongue splint here are used to stabilize injury for arm, as you see it like a U shape, and the wrist by so stable the wrist and the forearm here and prevent forearm rotations and the wrist motions. It can be have some minimal movement in the wrist, but do not allow any rotations or excessive movement of the wrist. Indication: initial treatment of distal radius fractures, initial treatment of isolated radius or ulnar fractures, initial treatment of fractures of the shafts, so both radius and ulnar, and post-operative protections of the forearm and wrist. طيب. Ulnar gutter here is a good for fourth and fifth metacarpal or proximal pharynx injury. Aim for intrinsic plus positions that when indicated, and don't ignore the rotational deformity before you immobilize. Finger splint, which is my favorite and easy treatment in the emergency, or body taping. It's useful for selected stable finger injuries when full casts are unnecessarily. Protect the skins between the digits and avoid over tight tape. Check the rotation, joint stability, and active motions before choosing minimal device. Maybe the problems with the toddlers and the young kids, that's will not allow it, and maybe they will bite it or take it away. So sometimes if that's impossible with young kids to go to the cast. Sling positions and elevations good for arm for device still phase if the limb hangs independently all the days. Teach the family how high is high enough during the first 48 hours. Need to be limb high up, so not allowed any swelling. Review finger motions and swelling check before discharge. Infant and toddlers, we have so many challenges with them. Very young kids, they may lose short upper limb cast, so we may need to apply full cast above the elbow or above the knee also. Longer cast may be hold position better in infant and toddler when the upper limb here is required, like these pictures. Small limbs, abundant soft tissues, and kids maybe play with the waters can make it a little bit challenge and make the cast to move or getting wet. Lower limb, I will go quickly because we are in the short time now. They choose the device quickly for the lower limb here, posterior short leg, common for acute emergency choice for foot and ankle injuries, and patient can't wait the pair. Stirrup or U shape here because we add inversions and inversions control around the ankle. Posterior stirrup, classic swelling ankles, fractures, combinations when stronger AB support needed here. Short leg cast, more rigid support after swelling settle or selected stable injury. The most important, when you send them home, ask the parents and the patient to elevate the legs so we're not getting swelling in the first day. Long cast, leg cast, which is uncomfortable but used with the knee control needed here, just some tibial, proximal tibial and unstable injury. Posterior short leg here, common acute emergency choice here, and easy for us, an emergency working there and fast. For the ankle, foot, or selected distal leg injury, usually hold the ankle near neutral unless the injury needs another position. Keep the toes visible here and bad to hear the geniusly here. Lower extremities, short leg cast. It's the below a knee. It's including casting of the foot and the lower leg. Indicated here for lower leg fractures, ankle fractures, severe ankle sprains and strains. So avoid to avoid any movement in the fracture area. Used to hold the leg or foot muscles and tendons in place after surgery or allow for healing. Apply the area below the knee down to the foot. Many patients after this cast, they need to go to the physiotherapy or doing some exercise to rehealing and restoring the muscle mass. Let's go to the workshop here. Okay. Posterior short leg splint here, common for emergency. As we mentioned it, usually hold the ankle near to the neutral and the injury need to another positions and keep toes visible and pat the head generously here. And many patients, they are comfortable with this cast. Here, the four steps, simple step, prepare, keep ankle near 90 degrees and measure slab length before wetting. Always prepare everything before you start wetting the cast. Bad, protect the heel and malleoli and the edge with a smooth overlapping bedding. This is an area for injury or bit sore later on. Apply run from the posterior slab from the toes under the heel to just below the knee, from down to up. Secure, rub gently, and hold shape while sitting. Then check the toes again, neurovascular examinations, and the color and the circulations. This is bivalves, but we can teach from that about the posterior cast, short leg. Okay, let's go with this U shape. As that's a stirrup or U splint that's add inversion and eversion control around the ankle and can be combined with a posterior slab for stronger iliac support. And it's useful with when ankle stability is the main goal here, but it allows some movement of the ankle for up and down. Actually, injuries and equinox position, which is most of the time you're having normal X-ray for that. That we need to be immobilized and rest the tendons here. Be explicit in the note that handoff, if non-neutral ankle position is intentionally that we keep it. And never assume all ankles should be placed at 90 degrees, maybe less, more wide angle. طيب long cast, it's above the knee for all proximal tibial and fibular fracture here and mid shaft fractures or severe spiral fracture here that we need apply cast to prevent all the movement in this area, and also for distal femur, distal fractures of the femur here if it's stable for course of course fracture. Bivalve cast, as we mentioned it, for the upper arm or upper limb and lower limb. Cast cut into two halves. When frequent inspection, we need it, or we may predict there's some swelling will happen to the limb. Pressure point. That's heel. Be careful about heel, malleoli, fibular, head, Achilles, and posterior of the knee. It's high risk area for the pressure injury. Most complaints begin its rubs before they become sore or burn. Children here, they cannot able. They said there is some pain or some itchy around here make sure we may need sometimes to open it and to inspect the limb again. A removable device may be fit here for some stable or minor fractures here. Low risk, better hygiene, comfort. During the sleep, they can move it out, but we'll inform them in the first days, don't remove it. Useful when the children can follow the plan and follow up it clear. Rigid casting, if that's not available device there, and also for unstable fracture, need stronger molding or high concern for loose position or poor compliance. Let me go quickly if the time within 5 minutes. Common fractures here that we have it, and we may not not able to diagnose it in emergency from the X-ray, like buccal fractures. It's one of the common faults that we miss it, especially with this small elevated and fractures. Sometimes it's much better to see it in the lateral X-ray. Green stick here when we have fracture from one side and intact from the other side, those injuries. This fracture is what you call it, green stick fractures in the toddlers and preschoolers. Supracondylar fracture here, that's grade 1 and maybe grade 2. We may need to have posterior long arm splint. Always check with any questions of any fracture here, either type 1, type 2, type 3, type 4. Check all the neurovascular examinations here. Scaphoid fractures, which is a common hidden fracture that may be easily missed in the emergency. And the clue for that is point tenderness here. For that, which is suitable here to do thumb spica. Metacarpal or boxer type fractures here, which is need ulnar gutter cast. Toddler fracture here, which is maybe spiral fractures here in the lower extremities. Immobilized choice vary by the local protocols, and short leg support may be sometimes enough for the child who will follow the instructions very well and not to be heavy work on the same limb. This is a toddler fracture, which is a spiral fracture for the tibia. Ankle injuries, sprain, or occult physical injuries, especially if the child unable to weight bearing. Even with normal X-ray, sometimes you need to go to the cast or short cast. Complications of fractures here, the pain, numbness, swelling of the fingers, skin irritations. Keep the cast dry. You may use the bag cast here so the child can get wash in the washrooms and getting cleaned by the parents. Request the parents to check the fingers and the toe, the color there, and keep it clean all the times here. Thermal injuries here and pressure sore here, like blisters from humidities and the area close here, they may develop thermal injury, or because over tight the cast having open wounds. Make sure, remember that wrinkles, dents, and unprotected bone may lead to the pressure injuries. Pain under one focus spot is more concerned than general soreness. Compartment syndrome here, which is our nightmare before and after cast. So it's about the pain, swelling, and change the color, either darkening or pale color of the skin. Paresthesia, numbness also, I feel hands fullness. That's maybe signs of compartment syndrome. Wet and loose cast, broken cast, and there's foul smelling. Maybe there is some hidden infections inside the bones, or there's open wound there that we miss it. So be careful about those complications. Parents teaching before the discharge. Elevate the limbs above the heart levels during the first 2 days or 3 days. Keep the cast dry. Never place object inside the scratch. Move the visible fingers or toes often unless they're told otherwise. Check the color, swelling, sensation, and comfort at home. and know exactly when and where to return to the emergency. Instruction to the school, instruction for the medications and the pain medications there, and when they have the follow-up with fractures clinic. When returns to the emergency, when you have numbness, tingling, severe pain, swelling, finger, the tips of the fingers or the hand change the colors, either dark or light. And if there's wet or broken cast, need to return to the emergency or visit the fracture clinic to reapply it again. Cast so and remove it here. Now, most of the time, we're using oscillating blade. Need to explain it to the child so he will not worry about the sound. And don't worry, it will not harm you. It will only cut the hard object. Sometimes we put headphone to the child so he will not hear the sound for that. Cast room checklist for safe. Explain the noise and vibration before touching the cast. Use the control, plug and fit movement rather there, and protect the skin. Be careful when we cut the cast and prepare hearing protection if that available. Check the skin carefully after we removing the cast. This is 8-year-old child having fush, which is meaning fall into outstretch hand here, which is having here. What's likely the fractures here, and what's the best method or devices to support the fracture here. Limbing the child with ankle or lower leg, 5 years old, with twisting ankle, lateral ankle tenderness, can be peri walk, but there's some swelling moderate. So, what's your safe for emergency immobilizations? Can we use the mobile device, the bristle, or the cast there? What kind of fracture? Which is most likely, as we mentioned, a toddler fracture here. Home message here, swelling, acute injury usually start with splint, not to be tight, full cast. And keep cast clean and dry. Keep the cast here when the instruction to the patient and for the family to return to the emergency. Many stable pediatric injury can be managed with a removable device when the diagnosis is correct. Parent teaching and written to the precautions are part of the cast care, not extra device. Padding, molding, trim lines, and the neurovascular examinations, neurovascular exam is very important point during assessment of the patient with suspected fracture. This is my references. I have so many references, I didn't mention it here. But most of my presentation, I get it from that reference in this slide. Thanks so much. I'm willing to receive any question from you. جزاكم الله خير. So our next lecture will be with Dr. Mohsen Saeed Najad. It's about understanding seizures in pediatric patients. It's a comprehensive approach. Welcome, Dr. Mohsen.
Hello, everyone, and welcome to this presentation entitled Understanding Seizures in Pediatric Patients, a Comprehensive Approach. My name is Dr. Saeed Najad. I'm a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I also serve as the executive director for translational science and population health at the Lundquist Institute for Biomedical Innovation at Harbor UCLA. In terms of disclosures, I am funded by the Emergency Medical Services for Children Innovation and Improvement Center, which receives its funding and support through the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And this is part of a grant that totals $3 million, with 0% of this being financed by non-governmental sources. This presentation would represent only my own personal opinions and does not in any way represent either the policies or the opinions of the Health Resources and Services Administration, the Health and Human Services, or the U.S. government. In terms of the learning objectives for this session, the goal is to understand the epidemiology and etiologies of seizures in children, to review management of active seizures in a pre-hospital arena, as well as to learn management of seizures in the emergency department among children, to review the dosing and routes of anti-epileptic medication administration in the ER, and to discuss emergency department aftercare for a child who is presented to the emergency department with a seizure. Pediatric epilepsy is probably one of the most common chronic neurologic disease in children, which peaks really around 5 to 9 years of age. The rate is about 375 for every 100,000 patients in the population. The range, depending on what part of the world you're in, is anywhere between 41 to 187 out of 100,000 population at all ages combined. It is important to have a systemic evaluation of seizure to understand how to classify it, any associations that the seizure may be part of, etiologies of seizure, as well as management strategies for seizure in children. Seizure is not a single disease. It is a heterogeneous group of neurologic conditions that manifest differently. The average annual incident of seizure is about 5 to 7 cases per 10,000 children, anywhere between the age of 0 to 15 years. Of all the seizures, about 0.5 to 1% of these end up being epilepsy. And as I mentioned, epilepsy is the most frequent chronic neurologic condition of childhood. A lot of times, the etiology of epilepsy is not ever going to be known. In about 25 to 50% of the cases, we can find an underlying neurologic condition. Usually it is either a congenital malformation of the CNS, a preceding trauma, some kind of an infection, some kind of electrolyte abnormalities, or inherited metabolic conditions and genetic factors can be identified as etiologies and causes of seizure activity. Some of the definitions that's important to know, and status epilepticus being one of them, the definition has changed over time. The current definition is a seizure activity, convulsive most likely, that is present for at least 5 minutes or more, that is continuous, or showing electrographic activities, or if you have a patient who has recurrent seizure activities without recovery between episodes. Any seizure activity that continues at least 30 minutes or at least 2 or more appropriate anti-epileptic medication doses have been given is considered refractory. And refractory is important because seizure that is refractory also has a higher association with irreversible neuronal damage. And not all seizures are convulsive. A lot of the times when we're talking about damage caused, irreversible neurological damage, a lot of it is related to convulsive seizure. So these are what we traditionally know as tonic-clonic seizures, where there's both stiffening and tightening of the muscles as well as the fast rhythmic convulsive movements. Over the past few years, there has been a really standardized classification for seizure types, and these have been basically now based on how the seizure starts. And this was developed by the International League Against Epilepsy. So as we can see to the left, focal onset is when the seizure starts as a focal, and then it may or may not develop into a tonic-clonic generalized seizure activity. Focal onset could be either consciousness is maintained or it could be loss of consciousness. The other second category is the generalized onset, that seizure starts general. And this will be either motor, which is like the tonic-clonic seizure activity, or non-motor, which is like an absence seizure. Either way, in a generalized seizure, impairment of awareness is present. And then there's the unknown onset. We don't know how it started. It could have been a motor or a non-motor, again, if it was a motor tonic-clonic versus a non-motor absence seizure. But this is important because we're looking at how it started versus how it's proceeding and how it's ending. In order to better understand what a seizure presentation involves, it is most important to get a detailed history from the witness or the caregiver who saw the seizure activity. They can tell you, did something start before the seizure activity? For example, did the patient all of a sudden stop talking and then their eyes rolled up and then they started having tonic-clonic, or did they just start having tonic-clonic, or did they just have a staring space? What happened during the seizure activity? How long did it last? And what happened after? Ideally, in America, there's a lot of those families who actually have a video recording of the seizure activity that they bring to us, and we can actually see for ourselves what the seizure was like. Also, whether there was any past history or previous seizures, whether there was any kind of neurodevelopmental disorders. We also would like to know if there was any history of preceding illness or a trauma. Any key features of the seizure, which again, like I said, was something around the time where the seizure activity was about to start, how long it lasted, was there confusion after the seizure ended? And then we'll add to that our careful neurologic exam to look for any focal neurologic findings or not. And often this is forgotten, but we also need to determine, was this an actual seizure activity or was it seizure-like, but doesn't really meet the criteria for a seizure activity. Febrile seizures are a specific group of seizure activities that are related to age of 6 months to 5 years. Usually the frequency of that is anywhere between 2 to 15%. Varies by region. In areas of East Asia, they can be as high as 15%. In the United States, it's about 2 to 5% of all children between 6 months and 5 years have had at least one febrile seizure. And it is probably one of the most common type of seizures activities in children, especially in that age group. Febrile seizures peak between the age of 12 to 18 months. They generally have no significant increase in the risk of long-term complications, and the treatment really mostly focuses on the cause of fever. If you can identify the source of fever and treat that, that usually helps resolve the problem. In terms of recurrence risk, I always tell my patients in the ED, if your child has had a febrile seizure, they have a 25% chance of having a second one. And most common of these repeats are going to be in the first 24 hours after the initial presentation. And it is actually very interesting because technically more than one seizure activity in 24 hours is considered complex. But given that there's such a prevalence of multiple febrile seizures in the same child during the same illness, I have found that our neurologists don't really do anything specifically extra for a child who's had more than one febrile seizure. They still treat them the same as having a single febrile seizure, even though we call it complex. So let's talk a little bit about how the approach to management of seizure in a pre-hospital setting would be. So in terms of pre-hospital care of seizure, the first line of medication use, if you don't have an IV established, which most of the times is very hard to establish in the ambulance in the first immediate minutes. So IM intramuscular midazolam is the first treatment of choice. There's, as I'm going to mention to you in a little bit, the intranasal version of midazolam is also starting to now become equally used because evidence is starting to support its efficacy. The first initial dose of intramuscular midazolam is around 0.2 milligram per kilo with a maximum of 10 milligram. And like I said, intranasal is also going to be similar dose, maximum of 10 milligrams. The reason being that, especially with both of those intranasal and intramuscular, some of the medication has dissipates and doesn't really get into the bloodstream. So because of that, the dose is higher than the IV dose. If you do an IV dose, the initial dose is 0.1 milligram per kilo with a max dose of 4 milligram IV. And this is, again, if the pre-hospital setting, they have IV established, and most of the times they would not have. So it's usually going to be intranasal or intramuscular midazolam. And this is by far the most commonly two choices of midazolam that are used. If you have IV established and you don't have a shortage, right now we have a shortage of IV lorazepam, but if there's no shortage of IV lorazepam, IV version of lorazepam is equally good to use. We do not want to use the IM version of lorazepam because it's not as effective. It actually takes longer to work, has a depot effect, and it doesn't really lend itself to being a good choice for managing status epilepticus in transport. Buccal midazolam could be an alternative. There's a second level of evidence, level B evidence for its usefulness. I don't know many of our agencies in the US that are using buccal midazolam. Also, the dose of midazolam given in hospital, in the pre-hospital setting, en route to the hospital, can be repeated if needed. So some of the times patients come to us, they have received already 2 doses of either intranasal or intramuscular midazolam. So in terms of stabilization and transport, all the patients who are presenting with seizure, whether the seizure is ongoing or stopped, you place them on a cardiac monitor during transport. You give them supplemental oxygen as needed. If the seizure has stopped, there's really no need to give additional doses of anti-epileptic, so you just watch them. If there's a febrile seizure, you treat the seizure the same as you would with an afebrile seizure by giving the anti-epileptics. If there is an opportunity to give antipyretics in the ambulance, that is also okay. A lot of our agencies here in Los Angeles don't really give antipyretics. There is evidence now the routine check of blood glucose may not always be necessary because there's not really a lot of low blood glucose is found in these unless they're neonates. But certain situations when a patient continues to have persisting seizure or any reason for it, it is good to check a blood glucose. If the patient feels obviously super hot and needs to be cooled, cooling measure is also a reasonable approach to have during transport. So one of the things that I was going to talk about, this is new evidence that's emerging for us. Currently, as I mentioned, the doses of anti-epileptics that are given by the ambulance is based on weight. There is some studies that are showing that this dose may not be effective enough, and as a result, a lot of the children who are having a seizure activities will continue to seize even when arriving in the emergency department. So the thought was that maybe there is some possibility of calculation errors, maybe the doses are underdosed. How about if there was a different scheme to dose midazolam? So there's this big study that our site is also part of. It's called Pediatric Dose Optimization in Status Epilepticus, PEDI-DOSE, that is actually continuing to enroll patients and collect data until July of 2026. And this study has 20 national centers, mostly involving children's hospitals. The question that it's trying to answer is, does pre-hospital use of an age range-based dosing improve time to seizure cessation before arriving to the ED compared to the current weight-based dosing? So this is ranging the dosing, and again, this is what that looks like. So the range dosing is now going to be, if you're greater than 12 years of age, you get 10 milligrams. If you're between 6 to 11 years, you get 5 milligrams. You are between 17 months of 5 years, you get 2.5 milligram. And then now we just started the 0 to 16 month to get 1.25 milligram. As you can see, this is no longer going to be a milligram per kilo, but it's going to be a straight dosing. And we're looking at that study right now to answer whether this way of dosing is going to cause in better seizure control and causing less children to arrive in the hospital still seizing. Other things to consider while the patient is in the emergency department is, like I said before, is it actually a seizure? Is it not? Is it brief or has it been prolonged? Is the patient arriving to the ER actively seizing post-ictal or are they back to baseline? So it's important to know their level of consciousness and any signs of convulsion. Is this a new onset seizure, or is it a seizure that is in a patient who has a known seizure disorder on medication already? And if we can determine if the etiology of the seizure is it fever, is it metabolic, is it a trauma-related infection? So very, very important to try to identify a potential etiology for the seizure activity. It is also very challenging a lot of times in the emergency department to know if the patient who's not actively convulsing, are they still having subclinical seizures or are they post-ictal? Sometimes, the eyes may be fixed, gaze deviation a little bit, the muscle might be a little bit stiff, but it's hard to know for sure. The gold standard is really to have an EEG monitoring on them. But both post-ictal and subclinical seizures don't have any overt signs of seizure. So you can check the heart rate and respiratory rate. Oxygen saturation may be lowered in both post-ictal patients and patients who are actively seizing. But post-ictal patients probably are not going to have as much of a tachycardia and tachypnea as those who are actively seizing. Checking the jaw, seeing if it's relaxed or clenched, fixed eye deviation, as I said, muscle tone, or how long has it been since the convulsions have stopped. If the convulsions just stopped like a minute ago, it is possible that you are still having subclinical seizures. So with the PDDO study that we're actually conducting right now, we are also putting a point-of-care portable EEG device called Cerebell on the patient so that we can actually see whether the patient is subclinically seizing or are they post-ictal. So this would be a transformation in the way we care for children. This device is very easy to use. It takes about 3 to 5 minutes to set up. And essentially, this is a headband that goes around the head. The clasp opens and closes in the front. And then those 10 little ports, you basically turn them left and right a few times, and then you press them, the gel comes out, and then it just starts kind of doing the EEG monitoring. So it's a very cool device that we're using. Just again to go over some of our managements that I mentioned before. This is part of the work that we developed through the AMS for Children program, the Pediatric Education and Advocacy Kits called PEAK for seizure. This is all documents that you can see and you can actually download later. It talks about, giving the midazolam, what you do with the blood glucose and how to treat the hypoglycemia in the pre-hospital setting, in the hospital setting, the 2 doses of benzodiazepine. And as I will say again, the plan is to do 2 doses and of the benzodiazepine and get the seizure under control within 20 minutes with the first-line agent. If the seizure is still persisting beyond 20 minutes, then you probably will need to go on to the second-line agent and not keep repeating benzodiazepine doses. And part of the initial management, it is ABCs, the oxygen, benzodiazepine doses, as I mentioned. If there's a fever, give antipyretics, check electrolytes, check anticonvulsant drug levels if somebody's on seizure medications that you can actually get the levels from pretty quickly. That will be important to do. And then in terms of our second line agent, if this is phase 2, as we say here, that starts 15 to 20 minutes in. This is after you have given your 2 doses of benzodiazepine already. These are the choices of medications that we use in the United States, especially the children's hospitals. They focus on the first 3. And these are all considered to be dose equivalent. So either you give 60 milligram per kilo of levetiracetam or 20 equivalents of phenytoin per kilo per dose of fosphenytoin, or 40 milligram per kilo dose of valproic acid. We consider phenytoin and phenobarbital as third-line agents, but some places might, especially places that see a lot more adults than pediatrics, they may jump into phenobarbital faster and use that as a second-line agent. But in pediatric centers, we are using the top 3 as our second-line agents. And there was a study published in New England Journal of Medicine a few years back, again, showing the bioequivalency and equal efficacy of these three options. So whichever one of them you have, we tend to favor levetiracetam at our site, but fosphenytoin is our second option. We don't do as much valproate, but all three of them are very reasonable to use. So if you have a patient with a seizure activity who's a known seizure activity, you can consult their neurologist, or if there's a patient that has a prolonged or a very unusual type of seizure, definitely warrants a first-time neurology consultation. You also need to keep them, as I mentioned, on cardiac monitor the whole time. The 2 doses of benzodiazepine, I'm repeating some of these again for you now, just to kind of make sure that we continue to emphasize the same points. And then fosphenytoin or levetiracetam, 20 or 60, those are dose equivalents. Then you have to decide which patient needs to be admitted to the hospital and get further care. Also, what level of care? Do they go to an intensive care unit or not? Some sites, and ours is one of them, we tend to intubate patients with complicated prolonged seizure activities more, which means if you are intubating them, then they probably are going to be admitted to the ICU. But just bear in mind that once the seizure breaks, things will change, and all of a sudden you have a child who was intubated, but now they're awake. So very important to consider intubation carefully. Refractory seizures, which last more than 30 minutes, and if the second line has already been used, then you're talking about going to the third line agent, and those third line agents are things like phenobarbital, ketamine, propofol, or ketofol. There is actually a new study that's starting up soon, within the next few months, that is going to be looking at ketamine as a potential agent to be brought in between the first and second line agents. So in other words, while you finish the 2 doses of benzodiazepine, would you start ketamine with or before you start a second line agent? And this study is looking at using ketamine with levetiracetam. And this is a placebo-controlled trial, which is either you get ketamine 1 milligram per kilo or 3 milligram per kilo added to the levetiracetam, or you just give levetiracetam alone, and to see whether the addition of ketamine can help improve stoppage of difficult refractory seizures. And then anytime you do a third line agent, you're probably required to protect the airway. Those patients probably should be intubated. Phenobarb, we can use anywhere between 5 to 20 milligram per kilo. Especially if you're going on a 20 milligram per kilo route, you definitely need to have the patient intubated. We would even do it with a lower dose, but 20 definitely. And then you can also have long infusions of anti-epileptics and final pentobarbital coma, which means high doses of pentobarbital at the rate of somewhere between 5 to 10 milligram per kilo per hour of pentobarbital. That requires specialized settings, EEG monitoring in the ICU. You basically keep them under for 12 to 24 hours, and then you turn it off. You check them and see if you need to put them back on again or not. But this is beyond the emergency department. This is something that gets done in the intensive care unit. Special consideration, remember, if it's a first-time seizure activity, it is important to have an MRI and EEG. We used to admit all of these patients to the hospital for EEG and MRI inpatient, but that practice has now changed in the United States. And most of these are going to be outpatient follow-ups to get an MRI and EEG study if the patient is stable and doesn't otherwise require any hospitalization. If the patient is already on a medication, you speak with a neurologist and see about adjusting their medication dose to see that this was not a breakthrough seizure. And every patient who has a seizure disorder who comes into the ER with a seizure activity should have outpatient neurology follow-up. Just a couple of brief things about infants. The neuroimaging is recommended for all infants, are basically neonates who have seizure activity, and this should be a high-resolution MRI to identify epileptogenic abnormality. Other considerations for neonate is that neonate is defined as seizure in the first 4 weeks of life for the full-term patient, And those who are preterm is up to 44 weeks gestation. The incidence of seizure in neonates that are full term is 2.29, and preterm can be as high as 14.28 per thousand live births. And you need to really dig into underlying etiology. Hypoglycemia is a common problem, sepsis, hypoxic ischemic encephalopathy, stroke, metabolic. Those are all things that contribute to neonatal seizures and epilepsy. And the difference with neonates and other children is that for neonates, phenobarbital 20 milligram per kilo IV is still the first line, so it's not benzodiazepine as the first line. But recommendation is that if seizure continues more than 5 minutes, you can still go ahead and give a dose of benzodiazepine. In terms of discharge planning, patients who can be safely discharged home are the ones who are stable, back to baseline. They have had no seizure activity during the observation time in the ER. Their labs and imaging, if they had any, were not abnormal. If they were febrile seizure, had no additional hospitalization need, they could go home. Those who have a clear, safe discharge planning, their primary care is easy accessible, they have a neurology appointment, they can go home. If there is medication that they're needed, it is a simple medication that can be prescribed at the time of ED discharge. But patients who need to be admitted are the ones who have complicated seizure, either they're non-convulsive or they're recurrent. Patients who had a seizure under the age of 3 months, those who have abnormal exams, lab testing, or imaging, they're probably not back to baseline fully. Those who required significant ED interventions such as oxygenation and airway, especially airway management. And those who need inpatient monitoring and further imaging, they also probably need to be admitted. This, I put the QR code here on the right. This is from our pediatric status epilepticus, pediatric educational advocacy kits, PEAK, from the EMS for Children program. Again, this is free for everybody to download. You can print it, you can make poster out of it, you can make pocket card out of it. And some of these sections that you see on the right, I already went through. And there's also a bottom line recommendation on the left, which kind of highlights everything that I went through pretty nicely in one place. So in summary, seizure is a complex neurologic condition that's made up of not just one ailment. It is probably a heterogeneous group of diseases. Etiologies are very diverse and varied, therefore. One of the common etiologies is febrile seizure, especially between the children of 6 months to 5 age, which is the age of febrile seizure. So the goal is to treat the cause of the fever, not worry so much about etiology of the seizure otherwise. In pre-hospital setting, midazolam intranasal or intramuscular is the first-line agent. We want to give 2 doses of benzodiazepine before we start second-line agent. As I said, the goal is to stop the seizure within 20 minutes with the 2 doses of benzodiazepine first line. And if not successful, then we go to second line. Admission for seizures is not automatically required as long as you have a good, safe discharge planning, as long as the patient has follow-ups as needed and have had no issues during observation period in the emergency department. Thank you again so much, and I appreciate having this opportunity to speak with you, and I'm hopeful that next time we can do this in person. Unfortunately, this year we had to do this by Zoom. I hope you still enjoyed and learned from this presentation. Please feel free to contact me, send me an email, or any questions you have. I'm happy to address those for you. Thank you so much.
Thank you very much, Professor Saidi Najat, for this excellent presentation regarding the seizure approach even before arriving to the hospital. Our next speaker now is Dr. Mahal Munif. Mahal Munif will talk about child maltreatment in Saudi Arabia from recognition to legislation. Dr. Maha Al-Manif. She is the founder of Child Abuse in Saudi Arabia and Family Safety. And she is a well-known activist in child abuse protection. And she is a consultant in infectious disease, pediatric infectious disease at King Abdulaziz Medical City, Riyadh. Dr. Maha, you can start, please. Thank you.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. First of all, I would like to thank the scientific committee for the invitation and thank them again for choosing the subject of child abuse in Saudi Arabia for the ER physicians. That was a great move. Next. I will talk now about the child protection in Saudi Arabia, an overview from recognition to implementation of the laws. I'm just going to give you an overview of what happened in the last 25, 30 years ago. The child abuse as a public health problem was only recognized in the year 2000 and was recognized by the media and the public, where cases of ugly child abuse were really in the newspaper back then. And this is really the recognition. Before that, there was a case reports from the healthcare sectors, and it was mentioned in the literatures of the psychology and social work, but was not really put on the surface until 2005, when it was becoming a public health problem. I think after that, the government and non-government organization start being established. So in 2005 to 2010, we have so many organizations established in Saudi Arabia that deal with child abuse, like the National Family Safety Program, some charitable organization, and also a unit in the Ministry of Social Services was established, a protection unit. After that, these organizations start working on the laws, and we start initiating legislations. So from 2010 to 15, the country so many legislations in this field. So we have the protection from abuse law that was enacted in 2013, and then the child protection law in 2014, and then we start having national studies, and we start having really good services at a national level, like the hotline for children, 116-111, and then the hotline, general hotline for violence and abuse, 1919. So 2010 to 2015, there was a lot of function and a lot of work other than the law and establishment of programs. Then in 2015, 16 to 2020, and until today, we are implementing Vision 23, where we have more specialized organization dealing with child abuse, such as Family Affair Council, and we have more specific law, like the sexual harassment law, the social status law. And we moved from just recognition of the problem and some case reports or some studies into really looking into more research and more prevention services. Next. So in the next 20 minutes, what I will try to do is to answer these 5 questions in order for us to know the status of child protection in Saudi Arabia. First of all, we need to know how big is the problem. We need to know what is the long-term outcome or consequences of child abuse and neglect. And then we need to know what is the role of professionals, especially the healthcare professionals, in child protection. And ER physicians are really in the front row. And then also a final question we would like to answer is where we are heading from here. So the first question is, how big is the problem? Is really child abuse a big problem? So this is next. So in order to know that, we will really give you an overview of the incidence of child abuse and the prevalence of child abuse. For instance, incidence is how the new cases registered, and now we do have cases reported to the health sector, There is cases reported to the social departments and to the legal department. For instance, for the health sector, we have the National Family Safety Registry. It's a national registry that was established by National Family Safety Program, and it really collects data from more than 120 child protection centers and team in all hospitals in the kingdom, in the 13 provinces. So this registry is a huge registry and collect data from the healthcare sector. The social services also collect data through the helpline 1919. They have a great database of knowing how many cases of abuse and how many call of reporting incidents of abuse. And then also the legal department, they do have data on the prosecuted cases. Next. For instance, I'm going to give you an example. Next. Can you move the slide? Next. Move the slide. So I'm going to give you an example of the National Family Safety Registry. For instance, this is a registry established in 2009, and it has been collecting data from the healthcare sectors, from centers and teams of child abuse in the healthcare from all 13 provinces in Saudi Arabia. For instance, in 2005, almost 2,000 cases of child abuse was registered in this registry. And if we look into the type of abuse, you can see that emotional and physical abuse is the most commonly reported. And you can see in this slide, the cases registered in the next slide. The cases here registered in the National Family Safety Program registry from the health sector. We started in 2011 of 188 cases from the whole country, and now we're seeing 2,000. It doesn't mean that the child abuse is really cases is increased, but the recognition of child abuse and recognition of mild cases of child abuse has been recognized and has been registered in the registry, so people are aware of the registry. So now in 2005, I have here until 18, but now in 2025, we are seeing about 2,000 cases registered in the registry. Next. Another data that collect incidents of child abuse is the hotline 1919. They have great data of all the calls that they receive on child abuse and women abuse. So you can see that for 2019, they have about over 4,000 cases of adult abuse, but they have doubled that amount, 11,000 cases of child abuse reported. And still physical abuse and emotional abuse being the most common, representing about 75% of the cases. So with that, looking into the cases reported in the National Family Safety Registry from the health sector and the cases reported in the social sector, we can estimate the incidence rate of child abuse being 20 to 40 per 100,000. I think this is similar to incidence of a common diseases like asthma or a common childhood disease. So the bottom line is really child abuse is really common, and like any other society or any other country, we are not really above or below any other places, whether international or regional. That will bring me to the next slide, or to the next question. The prevalence of child abuse. So this is the incidence. These are the registered cases of child abuse from the health sector and from the social sector. So let's talk about the prevalence of the child abuse. Is it really prevalent among, and this is usually done through research. So prevalence of child abuse, we did the studies. I'm sorry. Okay. We did studies section of the first question. Thank you for, I'm sorry for the interruption, but that will bring us to the second part of to answer the question is how big is the problem, is to know the prevalence of CAN. of child abuse. And to know the prevalence of child abuse, this is really based on studies. So the biggest study that we did in Saudi Arabia is using the SPCAN, child abuse and neglect screening tool. And this is instrument that's used in different countries in the world, so we can compare ourselves to others. In this study, we did a sample of over about 20,000 students between the age of 12 to 18 years who can answer a questionnaire, and we asked them about their childhood and if they are exposed to violence. And you can see emotional abuse score was the highest, was 81%. They said they score positive in emotional abuse, then followed by physical abuse, 64. And look, I mean, sexual abuse was 13.5%. They said that they have encountered a sexual abuse in the childhood in the year before that we asked them. So this is a prevalence of child abuse among secondary school children in Saudi Arabia. This was done in 2012. Next slide. Next slide. So this is really the result of the prevalence. So you can see, I repeat, emotional abuse is about 81%, physical abuse, 64% of the students said that they have been physically abused in the last year, and sexual abuse about 13.5. So that will bring us to the second question. Second question is, what is the long-term outcome of CAN? So if CAN is really common, so maybe it is really simple disease that we don't have to worry about it. But to know if the problem is big, so does it have a long-term outcome? And the best study that will take us to the second slide to look at the outcome of child abuse. Next. The biggest study that we did to know the outcome of child abuse is the ACE study, or the Adverse Childhood Experience study. This is a study done in 2016. We did it on about 10,000 adults were enrolled in this study. And we asked them, we use the Adverse Childhood Experience International Questionnaire. So we will be able to compare ourselves to other data from any part of the world. And we ask a question, we ask adult question about their childhood. Have they exposed to abuse in their childhood? And then we start looking in the outcome on their health. Next slide. We ask about 13 questions, or not question, 13 category. There's plenty of question in each one in order to determine if this person has been exposed to, for instance, domestic violence in the household was 57%, and then emotional abuse was 52%, physical abuse was 42%, and then you can see that sexual abuse was 21%. Also, living in dysfunctional family, living in a household where there is a drug abuser, or a person, one of the parents have mental illnesses, or one of the family member incarcerated. That means it tells you that the household problems is really huge. So it was about 10%. So we collect all this information, and then we start to link it. Is the people who have many of these events happening in their childhood, do they have a different tendency to physical diseases, to mental illnesses, and to risky behavior? And what we found, for instance, we found that 80% of the population that we studied, they said at least they have one of these incidents that I mentioned earlier, at least one ACE. Only 20% they said they never had any of these incidents. So what we did, and some of them they have 2 incidents, some two risk factors, some they have 3, 4, and 5. So what we did, we looked into these 30% at the end, the people who had 4 and 5 and more adverse childhood experiences during childhood, and we compare them to the people who had 0, 1, or 2 ACEs. And what we found is that the risk doubled, the risk of chronic diseases doubled in the people who have 4. Next slide, please. Next. So what we found is the people who had 4 or 5 ACEs, they tend to have double the risk of having chronic diseases such as diabetes, hypertension, or congestive heart diseases or obesity. So you can see for diabetes, then the regular or the national incidence prevalence is 12%. In these patients who have 4 or 5 ACEs, it was doubled to 26%. Next. Also, we looked into mental health. Actually, mental health, the effect of the people who have 4 or 5 ACEs, the effect was much higher, was like almost tripled. So depression in the people who have 0 or 1 ACEs was 6%. In people who have 4 or 5 ACEs, they have the depression rate was tripled to 25%. Next. Also, we looked into adaptation of risky behavior. So drinking alcohol, we found like trying alcohol or drinking alcohol in 0 to 1 ACEs was in 3% of the people who did have a low scores compared to 22% in people who have higher scores. The same thing for drug addiction. Next. And also we found that there is differences in the outcome of childhood experiences or child abuse into the adult female and males. For instance, if you see the blue are the males tend to go into risky behavior as a long-term consequences of child abuse, while female tend to go into mental diseases or mental illnesses as a consequences of childhood adverse experiences or child abuse. When we looked into chronic diseases, there was no difference between male and female in developing chronic diseases. So female tend to internalize the effect of child when they are adult, internalize the effect of child abuse into them, while male, they tend to externalize it. They have more of external symptoms. Next. So we can really conclude that our childhood could determine our destiny as an adult. So we really need to work more if we are into adult medicine. Adult medicine would really like us to work more onto having really healthy children not exposed to violence in order to decrease the rate of chronic diseases, mental illnesses, and risky behavior. Next. The second question we need to answer is what is the role of professionals? What our role as a healthcare professionals in child protection? Next. So all of you need to know that we as a healthcare provider, and based on the child protection law and based on the protection from abuse law, that we are a mandated reporter. And according to Article 3 and 4 in this law, in the child protection law, it really says that all people who work with children, such as healthcare workers, they are mandated to report child abuse to the Ministry of Social Affairs, or now called Ministry of Labor and Human Resources and Social Development, Ministry of Human Resources and Social Development. So you are a mandated reporter. So all of us as a pediatrician, as an ER physician, are mandated to report these cases to the ministry. Also, our role is not really just to report abuse. Our role is to recognize child abuse in order to report it, and also to screen for child abuse to start implement prevention program. Also, we really need to all have policies in our hospital. Next slide. No, the one before. Before. Okay, here, yeah. We all need to screen for child abuse in our clinics to identify early signs and symptoms of child abuse and start putting a prevention program. And also we need to have policies in our hospital. And now, as you all know, that the scan subspecialty is becoming recognized in the council, in the health council. And I urge really ER physicians and pediatricians to go into this subspecialty because we have really shortage of this. And also implementation of prevention programs such as parenting program, and continue to do awareness. Next slide. That will bring us to the last question. Where are we heading? Next. We are heading toward really changing our attitude. We are proud of our culture, but a lot of time we tend to have an attitude toward child abuse that it is normal, corporal punishment is okay. We don't want to really to interfere within this is a family situation. So this attitude need to be changed, and we really need to look at child abuse as a public health problems, as a medical problems that need to be recognized, treated, and this family need to be supported and reported for services and direct them to services. We need to change some of the legislations. We do have a child protection law, which is good. We have abuse law, which is great, but we really need to have more legislations. Like, do we have legislation that prevent corporal punishment at home? Do we have legislation that protect children in the street? Legislation for anti-bullying? All these legislation need to be implemented. Of course, women and child empowerment is really the cornerstone of empowering a family. It's very important. Also, we need to start implementing prevention programs such as parenting programs. And we need to do more research on prevalence, risk factors, and outcome of child abuse. Next. So this is an example of how we can change the attitude. For instance, corporal punishment. It's from the eye of the public. It is one sort of discipline of children, and it is acceptable. It's culturally acceptable as because I love my kid, then I hit my kid. But from a perspective of child protectionist, it is a form of physical abuse. And the child now today is with mild injury. We have seen children with severe injury secondary to corporal punishment in a good families. Also, we see corporal punishment is really have an effect on the development of the child and the psychosocial development of a child. And this has been proven over and over in studies, and it results in also in behavioral problem. So from our eye as a child protectionist, we know that corporal punishment does not work, and it causes really major behavioral problem, and it's been practiced a lot. So we really need to change the attitude of the people, of the public about corporal punishment. Next. So, for instance, we are really doing now a campaign. This is a global campaign called No Hit Zone. So we are really giving it to organizations such as hospitals, even supermarket, and then to declare their place as a no hit zone to educate parents that hitting children is a form of child abuse, and it is not acceptable, and it can cause behavioral problem in children. Of course, not everybody going to have behavioral problem. We are always, and this is the argument that they use with me is we are been hit as children when we are okay. Of course, not everybody going to have problem, but some people will do have problems from corporal punishment. Next. Also, where we are heading, we really need to change some of the law. So, for instance, I just put one example is, can we adopt Article 7 in the CRC where it prohibits corporal punishment at home, not only institution. Saudi Arabia have a law that prohibits corporal punishment in schools, but we do not have a law that prohibits corporal punishment at home. I know it is very difficult. It has been implemented in about 75 countries in the world, and the only Arab country that signed this mandate is Tunisia. Is the only Arab country that signed the no corporal punishment at home. I hope that we'll see more, because it really can lead to violence. Because if we accept corporal punishment today, which is mild, then tomorrow we might accept something really heavier. I'll stop here, and thank you for your attention, and I'm open for any question. Thank you.
Thank you very much, Dr. Maha, for this overview of child abuse. And if there is any question, we'll send it to you, and waiting for the response. I think there is one question about the cauterization. We send it to Dr. Maha and we are waiting for her response. But frankly speaking, I think this is considered now to be one of the child abuse tools that being used for children. So because we are seeing these cases in the emergency department, and we are reporting this to the scan team, and they are questioning the family about this. Okay. Our next speaker is Dr. Emily Rose. She will talk about upper airway emergencies, air management, and airway management strategies. Dr. Emily, you can start, please.
Hi, everybody. I am so excited to talk to you about upper airway emergencies and airway management strategies. This is a very life-threatening potential situation, and I'm really excited to talk about some cases as well as some pearls and pitfalls to the management of the pediatric airway and, acute airway management strategies. So first of all, stepping back. Now, compared to an adult, kids are really incredibly predisposed to respiratory failure. Now, this predisposition is actually both anatomic as well as physiologic. So anatomically, because they've got these, and partly why they're so cute, they've got these big heads. They have this sort of easy, soft, compressible, easy to compress airway, big floppy tongues, and just positionally, they can compress their airway pretty easily. Additionally, physiologically, they are absolute oxygen machines. They chew through this. And their apnea time, their safe apnea time is incredibly short. So the average adult, if young, healthy, pre-oxygenated adult, you could actually paralyze them if they're well pre-oxygenated and not intervene at all, do nothing. Now, I don't recommend you do that, but you could do that. And many of those patients will start breathing on their own if you pushed succinylcholine and didn't intervene. Many of them will start breathing on their own without intervention because they've got that 7 or 8 minute safe apnea time, and that succinylcholine could wear off and they could breathe again if you pre-oxygenate them. Again, please don't do that. That's not ethical against the Hippocratic Oath. Oh, but in contrast, so that's the average healthy adult. In contrast, the average 6-month-old has about a 90-second safe apnea time. Meaning, if you pre-oxygenate them, no matter how well you saturate those oxygen molecules, they desat very, very, very quickly. So you must be very quick in your intervention because they chew through, oxygen. They are high oxygen metabolizers. Additionally, kids are very, they get sick more frequently, and then everything's small up here, and the infants are obligate nose breathers, and the airways are small. So even, what's a cold to you and I can become significant respiratory distress in a younger child with, smaller airways. And it's really important for us to remember when we take care of kids that 95% of all cardiac arrest in children is of a respiratory etiology. So really to spend time on that airway and breathing, that'll help. That'll, solve the problem with most of your, circulatory problems. It really is an airway and breathing problem. So kids have very little reserve. So I already talked about the higher metabolic rate, that high oxygen compensation, but just the anatomy, they're compliant chest walls, they've got more horizontal ribs, they get tired quickly, they don't have that musculature, and then plus the smaller airways, the not obligate nasal breathers. They have faster desats due to that lower functional residual capacity. And oh boy, that, atelectasis, prone to VQ mismatch, they are really set up for respiratory failure. So this graph, I really love this graph from, this is published in the Rosen textbook, just demonstrates how little safe apnea time we have after pre-oxygenation, and those young kids in particular. It's just not much time at all, about 90 seconds. Now, kids normally have different respiratory rates at baseline. But, and this is demonstrating what's normal for based on age. But a higher respiratory rate is often, it's just a data point that we need to pay attention to. It's compensation for something. Kids are compensating. It's not necessarily to the point of failure, but we need to be aware and notice the early signs of respiratory distress. And what are common causes of respiratory distress? Now, we're primarily talking about upper airway, but overall, in infancy, bronchiolitis, pertussis, congenital, and anomalies, anatomic issues. That's a common cause. Toddler, this is very upper airway, foreign body aspiration, and croup, very, very, very common causes. And then children, you tend to have a little bit the lower causes of asthma and pneumonia, but anaphylaxis as well. It tends to be both combination lower airway and can be upper airway. I had one of the most severe anaphylaxis patients I've ever seen yesterday, and she required just epi drip and multiple doses of medications. And she was, despite being on epinephrine, she was her oxygen saturation was low 80s. It was really, an exciting case. Thankfully, she did well. So rapid assessment of impending failure, you really, want to look at your overall appearance, and that how does the child look? Are they interactive? What are they doing? Are they completely oblivious, apathetic to what's going on? Or are they, appropriately crying when you try that young child getting mad at you when you're trying to evaluate them? Worker breathing, note, are there retractions, nasal flaring, grunting, head bobbing, or abdominal breathing? And circulation, we want to feel the temperature of the skin. Look at the coloring, check out cap refill. Those are all important data points in assessing the child. You want to look sort of upper and lower airway, generally, to look for signs of respiratory distress, look for signs of stridor, drooling, tripoding, wheezing, a prolonged expiratory phase as an obstructive pattern, crackles with pneumonia, if there's equal sounds, and then more of a CNS abnormality or neuromuscular issue if there's disordered control or irregular or weak cry. So just a note before we get into a few more, serious cases, just a reminder that most viral respiratory tract infections are viral. There's not really any medications that we can give to treat, to speed things up. Much to my children's disappointment, they think, oh man, what's the point? What's the benefit of having a mom who's a doctor if she can't make us feel better any sooner than other moms? So unfortunately, I don't have any magic in that regard. But there's no indication for antibiotics. Bronchitis, bronchiolitis is unlikely to have superinfection. Sinusitis, you really want to treat if you have 2 to 3 weeks of significant periodic discharge and pain. Nasal saline rinses is the initial treatment. Cough, prolonged cough, the average cough lasts about 2 weeks, and you can have, reactive airway issues, and a more prolonged cough doesn't necessarily mean antibiotics is the therapy. And we want to avoid, because of reported death, antitussive medications in young kids under 4 years of age. The medicines don't really work anyway, but honey is much more effective. That dark, thick honey, buckwheat honey, or buckwheat honey, blackberry honey, the darker, thicker tends to work a little bit better. So let's talk about our first case. So we have a 13-month-old who comes in with acute choking episode. And actually, this kid was actually the younger sibling of another kid who you were seeing. This kid was perfectly healthy, had no problems, no cough, cold, runny nose, nothing. He was just accompanying the older sibling who was there for a fracture. But mom had some peanuts in her purse, and this child got a hold of them. And so it was a very abrupt onset of a choking episode. This child is not looking good, having acute stridor and acute distress, and not sounding great. So a couple of comments about foreign body aspiration. This should always be on our differential, especially in the young kid. Unfortunately, It accounts for a number of childhood deaths each year. And most of those deaths are in the infant and toddler age kid. So when we are handling this, we can't forget, we're so used to our, big fancy equipment, but don't forget about basic life support and utilize gravity. So in that kid, 1 year of age that you can have in your arms, do those back blows and chest compressions and utilize gravity, get their head down. I have a friend who, as a child, choked on a little, fruit roll up. And her non-medical trained dad did, listen to his instinct. He basically just picked her up by the ankles and started shaking. So remember gravity, and that worked. But utilize gravity and basic life support initially, and then we may need to move to advanced techniques. And the next thing we would try to do is take a look in the airway and see if we could actually grab it with some sort of forceps. If you can't grab that object and they have acute obstruction, you will want to intubate and just push that tube down to a right main stem and make sure that's actually why a lot of tubes have a port on the side, because there was a horrible case many, many years ago before that they had that tube on the side and the tip of the tube where the physicians wonderfully intubated the patient, did that, right main stem, and then pulled it back, and that little piece of apple that the child choked on was stuck in the ET tube, and the child could not ventilate. So that's why we have that little open port on the side. So don't forget to do that. And we'll talk a little bit about needle crike, should that be necessary at the end. But don't forget, even in your attempts, if this is not going well, don't forget to put on oxygen, nasal cannula. You want as many oxygen molecules getting into the body as possible. So support nasal cannula, try to get it in. Obviously, foreign body aspiration is a contraindication for an LMA, but try to do something. Don't do nothing. And you can escalate to needle crike, which we will talk about more towards the end of this. But what tends to be more common. So that's the sort of emergent, like, what do I do? Basic life support, try to get it out, then intubate right main stem. If that's not working, then you move on to the needle crike. What is a little bit more common is that patient where maybe they had a choking episode. Did they aspirate something or did they not? I'm not entirely sure. And that can be a little bit tricky. And so the literature on this is sort of a little bit helpful, but not all that helpful. So if a child has a witness choking event, clearly was struggling, and then has an abnormal physical exam, that's probably a foreign body aspiration. It becomes less clear if it wasn't witness unclear, the physical exam is questionable. Imaging. So I was always taught, in that situation, you do x-rays, maybe a lateral neck, see if you see anything, and then that chest x-ray, and then do inspiratory, expiratory, or, lateral decubitus to see if there's evidence of a ball valve effect where you're laying down and that the lung that you're worried about, it's usually the right side because the right main stem, foreign body aspiration, when you're laying down, that actually is more expanded because of that foreign body aspiration. Well, that's helpful if you see it, but again, it's neither sensitive nor specific in the literature. It hasn't really panned out. So if you are concerned about the abnormal history, abnormal physical exam, really the treatment is to be evaluated with a scope, do a bronch to evaluate for foreign body. And I've diagnosed 2 different foreign bodies. You can have lower airway, so an airway foreign body that's up here and then gets choked down to a lower airway foreign body. That can be present in the lower airways for days, for weeks, for months, even years. And I've had 2 cases over the years of patients that have had recurrent pneumonia, especially right lower, right middle lobe pneumonia. They get pneumonia, they get treated, they get better, and then it comes back again in the same spot. Well, that's classic for a lower airway foreign body that was aspirated, and you get recurrent symptoms. So be aware that can happen. And the only really way to diagnose and treat is to do a bronch. Now, there are it has been reported that CAT scan or MRI is another way for a larger foreign body. Again, not quite as sensitive as bronchoscopy, but that is an option as well. Now, I want to say something about button battery ingestions. These are very, very critical that we make this diagnosis. So helpful, this is when an x-ray is helpful. You classically see that sort of, it looks like a coin on, first glance, but then you see that halo, that rim, and that sort of double layer on the lateral x-ray, that sort of step off. And that is really, really important, time sensitive, because this can cause all sorts of damage. These patients, especially young patients, have significant just necrosis in the chest and tracheoesophageal fistulas. And then you can have just terrible outcomes, permanent scarring, all sorts of issues. So if you make this diagnosis, this is a time sensitive, this is an emergency, you need to get this out. If you do not have the ability to scope in where the hospital that you are practicing or in the clinic, you need to get them to a place where they can be scoped as soon as possible. There's some studies demonstrating that honey's amazing. Honey can help sort of slow the damage a little bit. So giving a child honey as you call in the consultant or transfer the patient may help decrease, of course, decrease side effects. Of course, it makes everything sticky. So talk to your GI doctor about that before you do that. So I could talk about foreign body aspiration for a long time, but I'm going to keep moving forward. But it's really important, just to sort of sum up what we've said about the foreign body aspirations, it's really important to always consider this in your differential diagnosis. History of choking is an important data point. X-ray can be helpful, but if you're really clinically suspicious, don't be falsely reassured by your X-ray, and get a bronchoscopy if you are suspicious. Next case, we have a 2-year-old who was maybe had a little bit of sniffles, and then all of a sudden had this, woke up in the middle of the night and has acute shortness of breath and sounds like this horrible animal seal with his cough, and has restring stridor on exam. Well, this is a classic presentation of croup, right? So most croup thankfully is mild. You have a little bit of cough, stridor with agitation. Moderate croup, it has mild stridor at rest and increased work of breathing. And severe, thankfully, is less than 1% of cases. Those patients have severe stridor, significant respiratory distress. Thankfully, this occurs in less than 1%. Now, croup is completely a clinical diagnosis. There is no lab test. There's a gazillion different, that's not really a real word, but there's a lot of viruses that can cause the clinical pattern of croup. Additionally, there's no imaging. X-ray is not helpful, so you don't need that. It's completely a clinical diagnosis. So if you have the diagnosis of croup, everyone that you should see should get a one-time dose of steroids. Anybody with stridor at rest or increased work of breathing should get nebulized epinephrine. The steroids have been studied. Dexamethasone is the most commonly used, and we can use the IV form orally. The initial studies were 0.6 milligrams per kilogram of dexamethasone, and then they looked at 0.3 milligrams per kilogram, and then even as low as 0.15 milligrams per kilogram. All seemed to be impactful. That said, the more severe cases did respond better to the higher doses. So, but the lower doses are non-inferior. The max recommendation does range in the literature from 10 to 16 milligrams. Budesonide has also been demonstrated to be as effective, but it is more effective. More expensive. Just as effective, more expensive. Nebulized epinephrine, the indications are stridor at rest or respiratory distress. If a child gets this, you should observe them for at least 2 hours. To make sure that stridor and increased respiratory distress does not recur. You can use racemic heparin or regular old crash cart epi. Both are demonstrated to be equivalent. When you see a kid with croup, remember to generate a differential diagnosis. So you don't make the diagnosis if you don't consider it. And of course, this is not a complete list, but there's many things that this could be, including foreign body aspiration, which we just talked about. And another important differential that we need to I would just like to mention is bacterial tracheitis. Now, most patients with bacterial tracheitis do require intubation. You can have a lot of mucosal sloughing and pus in the airway, and these patients can be pretty sick. How this looks is you tend to have a little bit, symptoms are a little bit longer. These patients tend to be a little bit more toxic appearing, and they're not very responsive to treatment. Croup is very responsive typically to treatment. So steroids plus a racemic epi, kids just look night and day different, but a kid with bacterial tracheitis would not respond so well. So everybody gets steroids, and then straight out rest or respiratory distress, give them nebulized epinephrine. A word on epiglottitis. We are not seeing this quite yet as much, thankfully, because we do have a lot of herd immunity, even in unvaccinated kids. But the classic, I've seen this a couple times in adults. It's much less exciting in adults. It's much more dramatic in young kids, but it's pretty classically abrupt onset. You don't have much of a prodrome, but these patients are kind of like sitting up, drooling. Really, I think it's helpful to remember the epiglottitis Ds, dysphagia, so pain, swallowing, drooling, and distress. They're really sort of sitting forward. They don't want to lie back. So think about this diagnosis. This is an airway emergency. A lateral X-ray, neck X-ray can show that thumb sign with a little bit of narrowing of airway. And you really want to take the airway in a controlled setting, ideally. You don't want to do a lot to make that patient mad. You want to get them to the operating room. So let's talk a little bit about airway management strategies. So first of all, high flow nasal cannula is very effective, that sort of modality that we use. It's not very invasive. Children tend to tolerate this quite well. And it's sort of a nice happy medium. It's a little bit more than our traditional regular nasal cannula. We can give it high flow, higher rates, right? And it's warm, it's humidified, it doesn't dry out as much. It does give you a little bit of PEEP, so about 2 to 5 centimeters of water. Now, the settings, recommended settings of this really vary, and I almost find it comical how much it varies depending on institution. Even in institutions in the same city, it varies. If you're or even in the same hospital, PICU versus ED. But usually settings are about 1 to 2 liters per kilogram per minute. In the younger kids, it tends to be a little bit higher. So you usually can't go wrong with 1 to 2 liters per kilogram per minute. But of course, this is going to give you a little bit of respiratory support, not too much, but it's contraindicated in apnea. It's not going to help you breathe if you're not breathing. So you have to breathing on your own. And this does help with the work of breathing, but it has a higher failure rate and moderate to severe respiratory, distress compared to non-invasive meaning non-invasive meaning CPAP or BiPAP. Flow, this is one chart that was in my textbook chapter that we used just depending on age. Again, you won't go wrong if you say 1 to 2 liters per kilogram. So non-invasive, let's move on to non-invasive. Now you can deliver this by, face mask, hoods. There's lots of different modalities. Even nasal, non-invasive is better tolerated. Obviously, this is not quite as effective as something that covers both the nose and mouth, but you have to do what you can get away with, right, in kids, right? CPAP and BiPAP, the dosing really is not, the settings are not different than adults. And CPAP generally started at a pressure of 5 centimeters and titrate up as needed. BiPAP, you start at expiratory pressure of 5 and inspiratory pressure of 8 to 10 centimeters of water and titrate as needed. Now, this is a talk on upper airway, but since we're talking about airway interventions, just want to say about bronchiolitis, since we use high flow and even non-invasive for bronchiolitis, this kind of applies to things other than bronchiolitis, but the contraindications to using these measures and when you need to escalate to intubation include apnea, if these measures are not working, if you have a patient who is altered, can't protect their airway, or hemodynamically unstable. So let's move on to airway and intubation. I mentioned that kids have short, safe apnea time. So you need to move quickly and have everything ready. The anatomic differences, the airway in a child is, we say it's anterior, but it's not really anterior. It's really cephalad. It's like higher up. And so when you're intubating, you need to get down and look up. That's really, really important to anticipate that. And the other challenge with intubating kids is that the equipment size is different depending on the child's age. And the positioning required is also different. So in an infant, because of that big head, you need a towel roll underneath your shoulders, particularly under 6 months. A small child, you may not need anything at all to really align that airway. And an older child, an adult, you'll put a towel underneath the head to appropriately align the airway. And I had to include this picture because my compliant daughter and her big head, she let me take this picture. Her twin sister did not let me even attempt it, but she's my very sweet, compliant child. Okay, so when you are bagging a child, remember, you want to get about 6 to 8 milliliters per kilogram of tidal volume, but with the dead space, it's about 10 milliliters per kilogram. And it varies depending on the size of the child. So you could technically bag anybody with an adult size, but you can only bag, somebody that's 12 kilos or less with a neonatal bag. So if you had to have one bag in your ED, it would be an adult. And the short story to this is that you really want to pay attention that you're bagging just to chest rise. You don't want to overinflate and get too much air, cause barotrauma. So the infants squeeze release, and older kids squeeze release release. Now, the equipment size can be a little bit challenging to remember all of these things in kids. And I can't, there's calculations for this. I can't really trust myself to do math in my head when I have a child dying in front of me, especially when it's like 3 a.m. So I remember just a few things. I remember at birth, I'm trying to get a 3-5 tube in. At 1 year, I'm trying to get a 4-0. I want a 5 at 5 and a 6 at 8 to 10 years. Similarly, blade size, I just like to keep it simple. I remember, now it's a little bit big, but I can get a 2 at 2. I personally love the Wiss Hipple, that 1.5 at 2, but I know around 2, there's a big difference between a 1 and a 2 blade, but about 2, I can get a 2 at 2. People often discuss and debate what, sedation meds, paralysis. Long story short, you get better intubating conditions when you sedate and paralyze patients. So we should do our best to create the best circumstances to take care of patients. So use sedation, use paralysis. Atropine has been controversial. Long story short, patients can become vagally sensitive, but often bradycardia associated with intubation is more often associated with hypoxia rather than that vagal stimulus. But just be aware of that. Have atropine ready, but it's not mandatory to use every single time. And I think the literature is pretty clear, and personal experience from experts out there is that the more complicated, the more steps you make to something, the more likely you're going to have worse outcomes. So keep things simple, but be aware that atropine, you may need it. Etomidate, the recommendation is to avoid it in sepsis because of the associated adrenal suppression. And I know I have just a couple minutes, so I'm just going to wrap this up pretty quickly. The 7 Ps of RSI are similar in kids compared to adults. Just remember, okay, have atropine ready. And remember, kids, especially, gosh, if they have really lots of air in their stomach, that NG tube is very, very important. And that may actually impact your ability to ventilate, to bag kids if they've got a very distended stomach. Now, the difficult airway in kids, thankfully, is rare. Please, please, please don't forget about LMA. And LMA absolutely can save a kid's life. Now, often you can bag a kid and they're responding very, very well to bagging. Please don't forget, if you're bagging a kid, don't waste time trying to intubate if they're bagging okay and still oxygenating. continue the resuscitation, and then come back to it. And utilize an LMA. You absolutely could save a kid's life. If you have trouble intubating, use an LMA. That is absolutely acceptable and can save a kid's life. So please utilize LMA. Obviously, you can't use this if you've got acute airway obstruction. You can't get in their mouth or they have significant airway trauma, but most of the time, this is a lifesaver. Now, I wanted to say something about needle crike. There's a couple of points about needle crike. Thankfully, we don't have to do this very often, but if we do, we could save a life. Now, this is not a definitive airway. This is just a temporizing measure. You are trying to get a few oxygen molecules saturated there to save that child. But it's not a definitive airway. The biggest success story I know of a needle crike being used is a child who choked on cantaloupe at his birthday party, and they couldn't get it from up top. They couldn't reach it with the McGills. And so they did a needle crike, and bagging through the needle crike actually pushed that piece of cantaloupe up enough that they could grab it. And then that child didn't need an airway anymore. And that's a great story for needle crike. Now, there's many kits available for this, but you can do this with equipment in your ED. So there's two ways you can do that. So either you can take the cap of a 3.0 ET tube and put it directly into an angiocath, and then get your needle crike that way. So you're using either a 14 or 18 gauge, or you can take a 3 cc syringe, take the plunger out, and stick a 7 or 8 cap ET tube and then connect that to the angiocath. That's a homemade needle crike kit for you. You want to bag it, if you're doing just flow, it's 10 to 12 liters per minute. You can even stick an nasal cannula oxygen tube in there. Or if you're bagging them, a 1:4 IDE ratio at 10 to 12 breaths per minute. Again, you're not going to be able to get much air in there. It's a tiny little straw, and you're just trying to get as much oxygen into that body as possible. Please keep a nasal cannula in as well to just get as much oxygen to this patient as you can, and you're going to have passive exhalation. If you're in the scenario of airway obstruction, you really even need to change that IDE ratio to 1:8 to 10 and decrease those respiratory rates to 5 to 6 breaths per minute. Again, not very effective ventilation. This is temporizing. Keep trying up top. Try to thread other things. Try other things to save this child's life. And so there's many complications associated with needle crike, but really the alternative is death. So please utilize this. And I realize I'm out of time, so I have a couple of slides on intubation, which I think I will, for the sake of time, just skip, but you will all have access to my slides. Just remember, in asthma, we have risks of barotrauma, so you really want to decrease that respiratory rate, decrease that tidal volume, decrease that IDE ratio. And just in summary, think about foreign body and stridor. Give steroids to all Coopers, nebulized epinephrine with concern. We have a lot of conditions that still kill children. Unfortunately, bronchiolitis, respiratory distress, foreign body aspiration. Croup can kill kids. So, be ready with your airway supports and have a smaller ET tube for that obstruction. And thankfully, a lot of children will see ahead of time before they're in acute respiratory distress. So utilize every time you see a kid, take advantage of the opportunity to educate parents, to make sure they have their medications, to have good return instructions, and they know how to intervene before things get critical. And with that, I will stop, and thank you so much for your time.
Thank you very much, Dr. Emily, for this interesting talk about airway emergencies. I can see there is a lot of question regarding the evaluation form. We have two different evaluation. We sent it yesterday and this morning. One for those who wish to claim CME hours from American College of Emergency Physician, from ACIP. Okay, they have a different evaluation form. And our evaluation, which is the Saudi Council for Health Specialties. And this evaluation, you have to fill it every day. You don't have to fill it once a day. You don't have to fill it like after every lecture. you can do it once a day. That will be enough, according to the Saudi Council. For any question, for anything regarding the comments or the suggestion for our conference and for future activities, you feel free to communicate with me. I think they sent my account in X, so we can answer you anytime, even after the conference. I will be more than happy. Okay, or if there is any other courses that you feel we should do. Now, the last lecture for today will be presented by Dr. Todd Shang. He will talk about multi-center networks, global impact on pediatric emergency medicine research, BCARN, BERN, PEM, CRC. Dr. Todd, you can start, please.
Hello, my name is Todd Chang. I'm faculty at Children's Hospital Los Angeles and the Keck School of Medicine at the University of Southern California in Los Angeles, California, in the United States. I'm happy to tell you perhaps a new topic that's been done in APEM, but we were talking about multi-center networks, especially with pediatric emergency medicine research. Our objectives for today are to basically list key research networks and why they're here, germane to our specialty, pediatric emergency medicine, and to discuss the effect of regional and international research networks. By the end of this, we won't cover this dramatically, but we will be able to plan the creation of local research networks in the Middle East and North Africa, which is a prime area for research networking. Before we begin, I just want to go over what really a research network is. And typically, it's a multi-center network that allows for slightly different topics of research, more than one, to happen using the same infrastructure, so same research people, the same data analysts, the same the data infrastructure or computer infrastructure, so that more than one research study can be undertaken at any given time. And so typically with research networks, what you're looking for are at least 2 or more different hospitals or sites, maybe even different departments if you're in a very, very large university, that collaborate together on a variety of different research topics. So typically you're not doing just one research and then calling it a day and ending your day. Rather, you're doing more than one research study, or you plan to do more than one research study, and therefore you need a larger network to sponsor and help. And most research networks start with a group of colleagues and friends who do research together. Maybe they're already in 2 different institutions, or your colleague from your same hospital moves for whatever reason to a different hospital and wants to collaborate after their move, in which case you get an informal network that feels like a group of friends doing research. And as the research grows or gets funding and the network infrastructure collects more and more centers, then you need essentially almost like a business plan, a hierarchical organizational structure that helps with different communication, getting more funding for and to sustain a larger research network for more research studies. Because of this, most research networks require several things in order to sustain itself. It usually requires some level of governance documents so that it's not just a small group of friends who dictate everything, but a reasonably transparent way of deciding which research studies to do, how to distribute work and funding. There needs to be a mentorship and a pipeline for mentorship, because as the research network matures, so do your investigators. Some of them may retire, the students will graduate, and you need some sort of pipeline to continue research. You must have infrastructure funding. This is pretty key, and even if it's not directly paid to the entire network, but each person within the network should have some funding or some infrastructure to help out with the day-to-day activities of the research networks. On the bottom, of course, you need principal investigators, and you really should have more than one. Typically, one in each hospital is at the very minimum. You'll need some level of staffing and personnel, which means research coordinators, data analysts, other people who make your job easier. And then you do need some strategy for both data sharing between different hospitals, different centers, or universities, and also a way of managing ethics, of research ethics, especially in emergency medicine. And if your research network spans different countries where the laws are different, that your network needs to accommodate for differences in laws as the research progresses. So let's talk about the conduct of emergency medicine research, and we're going to look at a couple of networks that are outside of emergency medicine to see what kind of examples we have. The types of studies with research networks can expand very greatly. You're pooling retrospective data. That's probably the easiest way to do a research network so far. You can also do data registry studies by claiming a data registry, which is its own data pool that's separate from any of the hospitals, and all the hospitals that agree to pool the data will become part of the registry. You can also do prospective observational studies where each site decides to study a particular disease or management in the emergency department, where research being conducted without any experimentation. And then finally, you can do randomized controlled trials or other quasi-experimental studies amongst different hospitals. Here's an example of a temporary research network. Really, it's a multi-center research network that looked at traumatic brain injuries. And so this group of folks who led the TBI working group characterized the prevalence and the types of traumatic brain injury, and essentially did a systematic review of all the research done in the Middle East and North Africa, the MENA regions. They found quite a bit of writing and research from individual countries as well as from individual sites, or maybe 2 or 3 different countries or regions. And one of the problems that they found was that there was definitely not pediatric focus. This was all ages. And because each of these studies were independent and not part of a research network, there was a substantially high heterogeneity. There's a lot of different ways that the data were presented. There are a lot of different inclusion and exclusion criteria that were different. And the format of how they analyzed the data were all different. So it was really hard, number one, to pool them together to make a cohesive meta-analysis. And number two, it was it basically outlined the need for future multi-center, multi-regional, and multinational networks to consolidate and harmonize the data. That means everyone is doing very similar things to data collection. Everyone essentially is processing the data identically so that you can all combine it at the very, very end. This particular review also only tackled a single topic, which is adult traumatic brain injury. And when we get to pediatric emergency medicine, there's still so many other diseases to be studied, and it's not usually feasible to have 13 different networks for every single disease. You want to start to have a research network that encompasses your discipline rather than just one disease at a time whenever it's possible. So that's where research networks come in, where a research network typically does not have a single disease necessarily, but has a whole variety of diseases or injury patterns that it studies. So here's an example of a research network. Oncology is one of our most likely research networks because of the rarity of specific cancer and oncological diagnoses. So here's a Pediatric Oncology East and Mediterranean group that also encompasses this area of the world, as well as North Africa and Southern Europe and all the way towards India. Again, the research networks do not necessarily have one disease. It may have a specialty like oncology, but not specifically a leukemia or specifically a rhabdomyosarcoma. This is a global health network, and it has a region within the Middle East and North Africa, the MENA regions, but this primarily focuses on some data collection for infectious diseases. And then I found this paper in 2022 that talked about what emergency research is like in the Middle East. Emergency research and pediatric emergency research is different than many of the non-emergency diseases, disease patterns, mechanisms, and research out there. Number one, none of your patients are necessarily predictable. You can't schedule them. Number two, there's a lot of issues with consenting and doing active prospective research while doing medical care in the emergency setting. And it takes a while before the culture of that research can inculcate into an emergency setting. It's not a natural place for research to always be there. So these two authors talked about their sparse emergency department related research, let alone pediatric emergency department. And then they propose a cultural shift towards the acceptance of emergency research and collaboratives because of the large number of variations in emergency care that happens to both adults and pediatrics in the Middle East and North Africa regions. Within our specialty, there are specific research networks in pediatric emergency medicine. There are currently accessible about 8 that's on the websites. There are some forming in East Asia as well as in Africa, but they're not particularly widely publicized in the English language web. In the United States, there are 2 different networks. One is called PCARN, which is the federally government-funded research network for pediatric emergencies, as well as pre-hospital care. That includes the ambulances and research on the ambulances before they get to us. The PEMCRC, the Collaborative Research Committee, is a non-funded society network from the American Academy of Pediatrics, and they specialize mostly in retrospective and survey studies. Different other regions of the world, including Canada and Australia and New Zealand, have their own research networks. So PERC and PREDICT are theirs. There's also PERUKI, which is the United Kingdom and Ireland, and then REPEM, which is the Research in European Pediatric Emergency Medicine that combines most of the European countries as well. And then the Spanish-speaking world, there's the in Spanish, it's in English, it's called SPERG, which is the Spanish Pediatric Emergency Research Group. So Spain itself as a country has a fairly robust research network within pediatric emergency medicine. And then in Latin America, which means Mexico, Central America, and South America, has what's called REDEPLA, which is the Red de Investigación, essentially the investigation group within Mexico, Central America, and the South America with the Caribbean as well. And what happens is that all these regional and country networks have funding that's usually associated with it from research studies or from the government. And when it comes time to worldwide pediatric emergency network research, it's hard to find funding, because most governments do not want to fund an entire worldwide research network. They prefer to fund their own country's network. So Global PEM Research Network, the PERN, was actually unfunded, but really a collaboration of all of the existing pediatric emergency research networks out there. So PERN, essentially, this is what the final, or at least the current logo looks like, is a conglomerate or an addition of all of the existing pediatric emergency research networks. Here's a brief informal PERN meeting in one of the pediatric academic societies. And this is a lovely article published in a couple of different places, including in Emergency Medicine Australasia, that talks about the birth of this network of networks. Again, we already have pediatric emergency research networks in different countries and regions of the world, and they decided to meet together, starting as friends and colleagues, and now moving towards a little bit more organizational format with PERN. PERN currently has these 8 areas, but it doesn't cover the entirety of the world. It definitely doesn't cover the Middle East and North Africa either. This was the Sentinel study that started it. So during the H1N1 pandemic in 2010, there was a lot of information exchange between different countries and each of our experiences with H1N1. And therefore, the groups of researchers who decided to study this infectious disease pooled together and formed the first pediatric emergency research network. Again, while this is very disease specific and infection specific, the intent of the research network was to open up a collaborative to study other pediatric emergency research with diseases. This includes toxicology, asthma, and most recently septic shock and fluid therapy, and all the way to different infections like SARS-CoV-2. So the PERN infrastructure and the people within each of the networks were always able to be summoned to study different things, even though most of the studies were actually unfunded. Again, it's very difficult to get a global funding agency, but each of the individual networks were able to contribute their time and effort. So PERN is looking for additional sites, including in Africa and the Middle East and in Asia, and so we can start pooling our resources and doing better and better worldwide global pediatric emergency medicine research.
Thank you very much, Dr. Todd. Sorry for the interruption. I think now we end for today, and all your question will be taken to our respected speakers, and we will send you the answer tomorrow morning. And as you know, if you have any question or any suggestion or any query regarding this conference or anything we can do for the future conferences, please let me know. And thank you. We will put again here the evaluation form for the ACIP, which is the American College of Emergency Physician, and for the Saudi Council of Saudi Council for Health Specialty evaluation. Thank you very much.